All right. Well, good morning. I know that people are just logging in now, but I'm Bob Shin. I want to welcome you to our fifth annual Patient Education Day. Um, I, Obviously, this has been an unusual year. And so normally we've done these in person. And I know some of you actually have attended all of our patient education days, but obviously this year we had to switch to a virtual format. So this is new for us and maybe new for you. But again, I do want to thank all of you for attending. So this is an example of one of our meetings these days. We don't meet in person, we meet virtually through Zoom. I did want to just briefly mention there have been some changes at the MS Center. So for example, Susan Stewart, one of our nurse practitioners, actually has moved still within Georgetown to work with one of our neuro-oncologists. And actually Cindy, who actually many of you may have spoken to on the phone, has retired. We miss them and we thank them certainly for their service. But we actually have some new faces as well. So you can see at the top screen, Dr. Edwin Serrano, who's currently our fellow and has done actually a tremendous amount of work within the department. We're excited to have him join us as part of the group. We also have in the upper left second row, Kimberly Foster, a social worker who's already in just a short amount of time become really irreplaceable in helping our patients navigate different social issues. So you can see other familiar faces. So we have Dr. Erica Mitchell up at the top, as well as Bethany Schreiber, our nurse practitioners who have continued to work with us. You can see Dr. Osborne, who's actually giving the first lecture. Dr. Brian Barry is directing the MS Center at Washington Hospital Center. So you may remember him as a resident and fellow. Now he's attending, seeing patients in DC. You can see Lexi Ahmad, our Director of Clinical Trials, and actually Faria Dr. Amjad, who directs from the medical side, the neurology, the MS clinical trials. Derek has been a key member of our research team and actually takes care of a lot of our IT. Of course, Dr. Tornatori, who's the chair of the neurology department and neurologist in chief, also a regional director for MedStar, which brings us to Dr. Hu, again, a former fellow who's been practicing, opening an MS clinic in the McLean, Virginia office. She also serves as director of medical education, by the way, at Georgetown, so she's extremely busy. You can see Jimena and Priscilla, two of our admin assistants. Bafur couldn't be photographed this day, but he's also part of our team. Gabriella is an essential member in terms of setting up infusion. So for any patient getting prior authorizations, Gabriella takes care of that, along with Lisa at Chevy Chase, who's not pictured. Galam is a member of our research team, and then Tracy, who's one of the infusion nurses, or the infusion nurse at Chevy Chase, so helping us extend our reach there as well. Now, I do want to just comment, this is our fifth patient education day, but the other four actually saved online. We have videos and a lot of other information at the website. So if you're not familiar with this, neurology.georgetown.edu/MS-center is our website. Actually, Derek I mentioned him earlier, but he's been done a great job in terms of updating and keeping that content current. So please check that out when you get a chance. One other announcement I'd like to make actually is Dr. Amjad took the initiative to create an educational program for patients with MS. So this takes the form of a monthly lecture series. So I did want to make sure that everybody was aware of this. So the fourth Tuesday of every month is a free lecture, an educational lecture, and Dr. Amjad's created an entire curriculum to last for the year. In fact, the third lecture is coming up. It's actually Dr. Osborne again. So what you can see on November 24th, Dr. Osborne will be giving a lecture. And again, this is something that's going to go on for the entire year. If you're not already connected through Patient Portal, if you haven't been getting our messages, you could contact Dr. Serrano. So edwin.serrano@gunet.georgetown.edu. All of these slides will be available online later if you don't get a chance to copy all of this down. And one other announcement, this is not just a Georgetown initiative really, but I did want to let our patients know that we're supporting the National African American MS Registry. So naamsr.org. This was actually created by some of our colleagues. So there are three MS specialists who happen to be, they're African American. They also all three happen to be women. Recognize that African Americans often are not as well represented in our clinical trials. Often there's a lot less information about African Americans with MS, and they really want to do something to change this. So for any member of our audience who's African American but lives with MS, please consider checking out their website, naamsr.org. All right, so I mentioned that this is really uncharted territory for us, but we really couldn't have put this together without the help of our sponsors. So I do want to take just a quick moment and thank our platinum level sponsors. So Biogen and Genentech are companies that actually provided educational grants to help support this program. Novartis and Viela Bio also were very generous and are serving as our platinum sponsors. We also have Mallinckrodt, EMD Serono, and Sanofi Genzyme, who are our gold sponsors, and Alexion and Bristol Myers Squibb, a little bit newer, to the space, but are supporting us as silver sponsors. And I don't know if you realize this, but on the main splash page before coming onto this webcast, you could see their logo. You can click on them. So that's our exhibit hall. So during our breaks or even before or after, I guess, our presentations, you could click on their different websites, basically. And there's information there, sometimes downloadable material. Some of them have videos or chat options. So please explore them and support our sponsors, without whom this program wouldn't have been possible. I do want to say one last thing. Just to create this video platform, we had the help of Coalesce MedCom. And so I do want to give a shout out to David Gottlieb, as well as Sarah Aikens, who really allowed this technology to happen. So thanks to all of you and to our sponsors. So we have a pretty packed agenda, actually. As I mentioned, we have Dr. Osborne presenting. We'll hear from Alexis from Lexi Ahmad, Dr. Mitchell, Deborah Riley. One highlight of all of our patient education days has been some form of movement, dance or yoga. And so we have dance and movement this time around. We also have Dr. Barry, Bethany Schreiber will help us with Q&A. And then we'll have more comments from Dr. Tornatore, and he's actually going to help to introduce most of our speakers. Just so you know, because this is a different format, it's not really possible for us to do sort of live Q&A, but there is a Q&A box, or should be one, through the Zoom platform. So all along the way, if you want to enter any questions you have during the presentations, we're going to hold on to these and actually try to get to as many of them as possible at the end of the program. So please, if you do have questions, just go ahead and type them in online for us. All right. All right. So now complicated, because I'm going to have to try to share a different screen here. So I do want to say Dr. Osborne, as many of you know, is our director of the Neuro-Ophthalmology Clinic. He also is the director of our Multiple Sclerosis Fellowship. And he sees patients with MS and neuro-ophthalmology. But today's a Saturday, and he actually can't use electronics on the Sabbath. And so he actually pre-recorded his talk for us. So I'm going to try to get that online. So without any further ado, this is Dr. Osborne, and he's going to tell us about neuromyelitis optica spectrum disorder, which is a condition that is very close to but slightly different from multiple sclerosis.
I'm going to get us started today by giving an overview of a separate disease called neuromyelitis optica spectrum disorder. This is a disease that actually sometimes is confused with multiple sclerosis, so it's very important that we actually are aware of what NMOSD is. So what we're going to do is review the definition of NMOSD, review the diagnostic criteria for NMO, review the differences between MS and NMO, and then we'll review some of the potential treatment options for this rare disorder. So NMO is also known as Devick's disease. It used to also be called opticospinal MS in Asia, and it was classically defined as patients who had simultaneous optic neuritis or transverse myelitis. So these patients would have severe vision loss in their eyes, and they'd also have paralysis of their arms or legs. And it was thought to be a severe variant of multiple sclerosis initially. Devick actually described this disease in the 19th century, and I'm just going to highlight the case report that he wrote up. It really gives a really vivid description of how we thought of the disease for a long time. He had a 45-year-old French woman who had headaches and depression who came to the hospital, and this is in 1892. And she was starting to have urinary retention, so she couldn't empty her bladder. And then 10 days later, she had complete paraplegia, so she couldn't move her legs. And when they looked in the back of her eyes, they noticed that her optic nerves were swollen, and she developed complete blindness in both eyes, and she unfortunately passed away a few months later. When they did an autopsy, they found that she had severe demyelination and necrosis of the spinal cord and along her optic nerves. So they recognized that this was something that was affecting the central nervous system, and like multiple sclerosis, it affected the spinal cord and the optic nerves, but this was a much more severe case. So for most of the 20th century, Devick's disease was thought to be a severe variant of MS. It was initially thought to also be a monophasic disease, so patients would have a severe attack, suffer horrible disability, but typically they didn't have any relapses. Frequently they would have simultaneous vision loss, and it was initially taught that their MRI of the brain would be normal. And this would help distinguish it from MS, where we know that patients can have demyelinating lesions and plaques on the MRI of the brain. So this is just the timeline showing the evolution of Devick's disease, or NMO. And really you can see there's a huge gap from 1894 all the way up to 2004 in our understanding of this disease. In 2004, a breakthrough came when the Mayo Clinic researchers found that patients with NMO had antibodies in their blood against a protein called aquaporin 4. We're going to talk a lot about aquaporin 4 this morning. This antibody was not only a marker of the disease in the blood, but was felt to also cause the disease and separate it from multiple sclerosis. When they first published this, it was very challenging, and it wasn't clear that everybody agreed that this was a separate disease from MS. But however, they started revising the criteria for NMO in 2006, and in 2015, it became quite clear that NMO is a separate disease from MS, and they had these revised criteria, and they now calls it NMO-SD, neuromyelitis optica spectrum disorder. And then in 2019, just last year, the first drug was approved by the FDA for treating NMO, and we'll talk later that 2 more drugs were approved this year for this very rare disease. So we now know that neuromyelitis optica spectrum disorder is an autoimmune disease of the central nervous system, but it is different from MS. It typically affects young females, but it's really rare in males. Whereas in MS, the ratio of females to males is about 2 to 1. In this disease, it's 9 to 1. So it's exceedingly rare to see it in men, although it does occur. And it's associated with this antibody in the blood called aquaporin 4. Whereas with MS, we don't have any blood tests that confirm if you have multiple sclerosis. With this disease, if you have the antibody, you almost always have the disease. Causes of relapses in this disease can mimic MS, so you can still have optic neuritis, transverse myelitis, and an odd syndrome known as the area postrema syndrome. We'll talk more about this later. So although it can be very similar to MS in that you can get optic neuritis and transverse myelitis, it's now known to be a separate and distinct disease from multiple sclerosis. So this slide is highlighting that the paper that was published by the Mayo Clinic in 2004 titled A Serum Autoantibody Marker of Neuromyelitis Optica, Distinction from Multiple Sclerosis. And this was the first time they were highlighting that NMO is commonly misdiagnosed as MS. This is happening much less often now because most MS specialists know to test for the NMO antibody, and we can help differentiate the 2 diseases. But at the time that this paper was published, it caused a lot of commotion in the MS community because there wasn't entirely agreed upon by everybody that it was a separate disease. But as time went on, more and more evidence has shown that the NMO disease is a separate disorder. So what does aquaporin 4 do? Aquaporin 4 binds to water channel proteins in the cells of your brain. The water channel proteins are in cells called astrocytes. Astrocytes are located in your brain, your optic nerve, and your spine, which is exactly where NMO causes the problems. When the antibody binds there, it activates your immune system. In particular, there's a protein called complement that binds to these antibodies, and that activates the immune system further, leading to damage and destruction of the astrocytes. Astrocytes are very important cells in the central nervous system. They help support the brain, the spinal cord, and the optic nerve function. When the astrocytes get damaged, that leads secondarily to damage of the oligodendrocytes. If you know anything about MS, you know that the oligodendrocytes are the cells that actually make the myelin that wraps around the cells in your spinal cord, your optic nerves, and your brain. So when your oligodendrocytes get damaged, you lose myelin. And when you lose myelin, you start having a lot of problems. And then next, the neurons and axons in the central nervous system also get damaged. So you lose three separate types of cells in the central nervous system. First, the astrocytes get attacked, then the oligodendrocytes, and then the neurons. And because of this, you can get severe disability from NMO. This slide is highlighting the plasma cells in the cartoon, which are part of the immune system, and they make the antibodies that attack the aquaporin 4 channels in the astrocytes. And the cartoon's highlighting a very large cell in the middle, the astrocyte, which supports other cells in the central nervous system. Once that gets damaged by the complement, other immune cells come in, and they can also secondarily damage the oligodendrocytes, and then eventually the neurons. So if this is happening in your optic nerves, you get optic neuritis, and this can lead to vision loss in one or both of your eyes. If it happens in your spinal cord, you get transverse myelitis. That can lead to symptoms of weakness or numbness in your arms or legs. It can also lead to bladder dysfunction, where you can have incontinence, and it can lead to very severe neuropathic pain. This can be electrical burning pain in your arms or legs that gets worse when you bend your neck down like this. And then finally, you can get the area postrema syndrome. I mentioned this earlier. This is where you get inflammation in a part of the brain called the brainstem. And this can lead to intractable hiccups, nausea, and vomiting. Not just for a few minutes or a few hours, but for days or even weeks. Patients frequently might end up in the hospital because they're dehydrated, and they're getting worked up by a gastroenterologist who's trying to figure out why they have so much nausea and vomiting. They'll get an extensive workup. There's no signs of any food poisoning. They might get a CAT scan of their abdomen, get a colonoscopy and an endoscopy. And the entire gastroenterology team can't figure out why this patient has intractable nausea and vomiting. Have they done an MRI of the brain or checked the aquaporin 4 antibody, they might have found the answer. Again, this is a very rare disease, so it's not going to be a common cause of nausea and vomiting. And most patients who have nausea and vomiting don't have NMO. So don't worry if you have some nausea. Why is it important to differentiate these two diseases? They are two separate diseases, and the treatment's different. In fact, it's already been noted that several of the medications we use for treating multiple sclerosis can actually worsen or aggravate NMOSD. If you're familiar with some of the medications we use for treating MS, such as the interferons, fingolimide, or natalizumab, there have been case reports of patients who were misdiagnosed or diagnosed with NMO, treated with those drugs, and their disease got worse. So it's very important when doctors are making the diagnosis to know whether you have NMO or MS. And they have different disease courses. We know that both diseases can have relapses, but typically early on, most patients have a fairly good recovery from their relapses from MS. Whereas with NMO, the relapses do not recover well, and the prognosis is much worse in NMOSD. I'm going to highlight here the most recent diagnostic criteria that were published in 2015. These are the criteria that led to the name change to neuromyelitis optica spectrum disorder. And there's two types of NMO. We have seropositive NMO, where you have the positive antibody, which is at about 80% of the cases. And then we have about 20% of the cases where we still suspect somebody has NMO, but they don't have the antibody positive in the blood. That could be because they have another antibody, or they just don't have detectable antibodies, and we don't understand the disease fully. Not every blood test is perfect, and sometimes patients don't have the antibodies. And then what I'm highlighting on the slide here is that there are core clinical characteristics that are associated with this disease. And again, if you look at the top three, again, it's optic neuritis, myelitis, which is inflammation of the spinal cord, and the area postrema syndrome. There are a few other rare syndromes that can be associated with NMO, including brainstem syndromes, where a patient might have double vision or vertigo. They could have symptomatic narcolepsy, which is a sleep disorder. But in general, most patients who have sleep disorders or narcolepsy do not have NMO. And then sometimes patients will have lesions in the brain on the MRI that are causing other neurologic symptoms, such as weakness, numbness, or vision loss. And while I'm mentioning that, I should mention that the MRI of the brain in most patients with NMO are now noted to be abnormal. They might look different from your MS patients, but whereas we used to teach that the MRI of the brain is normal in NMO, it's now well recognized that the MRI scan of the brain is frequently abnormal in NMO patients. So how do patients typically present when they have NMOSD? Most of them have inflammation of the spinal cord for their first attack, which is also known as transverse myelitis. The second most common presentation is optic neuritis with vision loss. And then the third most common is the area postrema syndrome, which I mentioned can present with intractable hiccups, nausea, or vomiting going on for days or weeks. Their other presentations are much less common. The prognosis for optic neuritis is much worse in NMO versus MS. These patients may end up permanently blind or have poor visual recovery, even despite treatment with IV steroids. And patients who are aquaporin 4 positive, who have that positive antibody test that confirms the diagnosis, are known to have a higher risk of having recurrent attacks of optic neuritis in the future. So not only can you tell the patient that they have NMO, you can tell them that unfortunately, without treatment, they're going to probably have another attack of optic neuritis in the near future. Data has shown that approximately 40% of patients with aquaporin 4 positive NMO will be legally blind in at least one eye within 5 years of onset of their disease. So what are the optic nerves? I've been mentioning them a lot. This slide shows the healthy picture of what the optic nerve looks like when the doctor looks in the back of your eye. The MRI here shows what the optic nerves look like. You can see here the bright 2 circles are the actual globes of the eye. Right is on the left and left is on the right when we look at an MRI. So when you look at this MRI, right is left and left is right. And the cable that's connecting the eyeball to the brain is called the optic nerve. When we look in the back of the eye as doctors, we can only see the very front of the optic nerve. And 95% of the optic nerve is behind the eyeball. That's why we typically need to order an MRI of the brain in orbits to see the rest of the optic nerve, because we have only a limited view when we look in the back of your eye. This MRI is highlighting inflammation of the left optic nerve. If you look at the right side, there's a normal appearing optic nerve, whereas in the left side, you can see the bright signal of the optic nerve. That is contrast that is leaking in to the inflamed optic nerve. You can see on both MRIs that the optic nerve is very bright. It might even be mistaken for a tumor when you initially look at this because there's so much thickening and swelling of the optic nerve. However, this is not a tumor, this is optic neuritis due to NMO. After a median follow-up of 8 years in patients who've had diagnosis of NMO, almost 50% of patients ended up legally blind in one eye, and 15% were blind in both eyes. Can we prevent this from happening? Before I go on to treatments to prevent that from happening, let's also highlight what the MRI looks like in transverse myelitis. Here you can see inflammation of the spinal cord. If you look at the MRI images on the left side of the slide, you'll see that there's a lot of bright signal in the spinal cord itself, which is abnormal in the lower part of the spine, whereas the upper part of the spine that connects to the brain has normal signal. On the right side is an MRI that shows the contrast leaking into that inflamed area of the MRI. Patients who have transverse myelitis due to NMO will require a walker at 5 years, 22% of the time. 8% of these patients will be wheelchair bound by 5 years. And again, 50% of patients who have NMO, their first attack will be inflammation of the spinal cord. And poor recovery is common, unfortunately, whether it's due to a relapse of transverse myelitis or optic neuritis. And finally, this is an MRI highlighting what the MRI, this is a slide highlighting what an MRI would show in a patient with area postrema syndrome. So again, these are patients who have nausea, vomiting, hiccups. You can see there's inflammation of part of the brain called the brainstem. It's a small area of the brain near where the brain connects to the spinal cord, and it helps control your GI system. So if there's inflammation there, that's why you can get the nausea, vomiting, and hiccups. So how do we treat NMO relapses? Very similar to MS, we initially will start off with IV steroids. Many of you might have had IV steroids for treating an MS relapse in the past. Frequently, though, these patients, because it's NMO, will have poor recovery and may require further treatment after the steroids are done, including something called plasmapheresis or PLEX. This is where a catheter has to be introduced, typically by surgeons or interventional radiology, and the blood is actually removed from the patient, filtered to remove the antibodies and the complement, and then after that's been removed, the blood gets returned to the patient. This takes several hours, per day and is typically done over 5 days to 7 days. So the patient is usually hospitalized when the plasmapheresis is done. While they're in the hospital getting their plasmapheresis, the patient will frequently need to be evaluated by physical therapy and occupational therapy, especially if they have weakness in their arms and legs. And if they have significant vision loss from the optic neuritis, they frequently will need a referral to a low vision clinic to help them cope with their vision loss. Prior to 2019, there were no FDA-approved medications for NMO. So after somebody was diagnosed and they got treated for their relapse, and they recovered from that, we would frequently put them on medications to weaken their immune system so they wouldn't have further attacks. The most common medication used in North America and worldwide typically has been rituximab or Rituxan, which is a monoclonal antibody that blocks or depletes part of your immune system's cells called B cells. B cells are known to be involved in making cells that make antibodies, and those antibodies include the aquaporin-4 antibodies. So the theory is by depleting the B cells, you'll have less cells making antibodies, you'll have less aquaporin-4, hopefully, and less relapses from the NMO. And the data seems to suggest it's a fairly effective drug, and it's usually well tolerated. However, it's not approved by the FDA for treating this disease, and in 2019, the FDA finally did approve the first drug, known as eculizumab. This is a monoclonal antibody that blocks a different part of the immune system called C5, part of the complement system. If you remember, I mentioned after the aquaporin-4 antibody binds to the astrocytes, complement is activated, and that helps propagate the immune system's attack against the central nervous system. So by blocking the complement system, the theory is that will block the NMO relapses and prevent disability from occurring by preventing future relapses. It's only approved for patients who have aquaporin-4 positive antibodies in adults. This is a frequently dosed medication, has to be given by IV every 2 weeks. Complement, remember, is involved in the immune system's ability to prevent infections, but also plays a key role in the NMO-SD attacks on the central nervous system. So to prevent infections from occurring, patients before they start eculizumab need to get vaccinated against meningococcal infections. Meningococcal infections can cause meningitis, and there's 2 vaccines that can help reduce or lower the risk of that from occurring. Patients are recommended to get the vaccine at least 2 weeks prior to starting therapy with eculizumab. In 2020, just recently, 2 more drugs got approved by the FDA for treating aquaporin-4 positive NMOSD. Satralizumab is another monoclonal antibody. It blocks a different chemical in the immune system called interleukin-6. In particular, it blocks the receptor for interleukin-6, which is again involved in the immune system's attack in the central nervous system in NMO. This drug is different and novel in that it is given by the patient themselves at home by a subcutaneous injection every 4 weeks. This drug may increase the risk of infections because, again, you're modulating the immune system. And finally, inebilizumab is the most recently approved drug. This is a monoclonal antibody that's infused every 6 months. Like rituximab, it blocks these B cells. It does it by blocking a different part of the immune system. It blocks CD19, which is a protein involved in B cell survival. So by blocking CD19, B cells partially get depleted, and then every 6 months the drug has to be redosed because those B cells start to return. Again, inebilizumab might also increase the risk of infections, as all these medications may when you modulate the immune system. Because the risk of relapses and disability is so high in patients with NMO, it is recommended patients start therapy and stay on therapy long-term to prevent further attacks. Once an attack occurs, unfortunately, it's very hard to recover from it. Relapses, as I've already highlighted, can lead to permanent blindness, paralysis, and in rare cases, even death. So the name of the game in treating NMOSD is prevention of future attacks with these medications that I've highlighted. What if you don't have the aquaporin-4 antibody, though? If you're antibody negative, there are no FDA-approved treatments yet. Some aquaporin-4 negative patients may have another antibody in their blood known as MOG. MOG stands for myelin oligodendrocyte glycoprotein. This is another test that can be tested by your doctor in the blood if your aquaporin-4 antibody comes back negative. MOG disease also can cause optic neuritis and transverse myelitis. So you can see how all these diseases can be confusing because their symptoms overlap so much. Many aquaporin-4 negative patients are still treated by doctors with immunomodulatory drugs, such as rituximab, which I already mentioned, or other immunosuppressive therapies like mycophenolate or azathioprine. All these are not FDA approved, and so you would have to have a discussion with your doctor about which medication would be best for you. In closing, if you have NMOSD or you want to find out more information about NMOSD, I recommend you contact the Guthrie-Jackson Foundation. I'm highlighting here on this slide their website address. They have on their website also an app that you can download that has a lot more information about NMOSD. Thank you again for joining us, and have a great day.
All right. Well, thank you, Dr. Osborne. That was terrific. As always, really a very interesting disorder that, as you can see, the therapeutics are expanding quite rapidly. I do want to extend a thanks to everybody who is logged in. Looks like we have over 200 participants, and that's fantastic. I see many friends out there, so wonderful. Okay. So next up, we have two folks. We have Lexi Ahmad, who is our Director of Clinical Trials, who is going to talk to us about the MS Advanced study, the results and racial disparities, and also Maggie Lana, who is one of our medical students who did some really interesting work this summer looking at social isolation in our MS patients during COVID, and is going to present that data. So I'm going to hand the mic over to Lexi.
Hi, good morning, everyone. It's really a pleasure to be here with you today. And like Dr. T said, what an incredible turnout. I want to thank everybody who organized this, especially Bethany. There's been so much work going on behind the scenes, and I'm just really glad we were able to do this today, even if it couldn't be in person. So this is an outline of what I'm going to be talking with you about over the next 10 minutes. I'm going to talk about our research team and introduce you to them. I'm going to talk to you about the MS Advanced study and show you some results from 2 projects that use the MS Advanced study data. And then you're going to have the opportunity to hear directly from our population health scholar, Maggie Lana. All right, so as many of you know, Georgetown, and especially the MS team, is known for doing research. And I have the pleasure of working with this amazing group of people who you see here on this slide. This is our incredible team of clinical trial coordinators, our regulatory manager, and some students who've been working with us, such as Maggie and Myra. And for those of you who do participate in a clinical trial currently or have participated, you'll recognize many of these faces and names. And so before going any further, I just want to take a minute to recognize their work, and everyone please clap. Please join me in clapping at home for a round of applause for them, because they are superstars every day. And especially during the pandemic, they have been working so hard to ensure that you're still able to participate in research during this time. And not only does this group of people take their work very seriously, but I can honestly say that we all truly enjoy working with you, and it really makes us happy to work with you. So on that note, I want to extend sincere thanks to all of you who have participated or even just expressed interest in being part of our clinical trials. I want you to know you're the reason that we do our job, and you're the reason that we're here today. So thank you. All right, so moving on, I want to make sure that everyone knows about our website. And our group is responsible for dozens of clinical trials in the department. And if you're interested in learning more about trials that are actively recruiting, please take a look at our website. You can click on the title of any study, and it's going to take you to a website called clinicaltrials.gov, which will explain in a lot of detail. And that website can be confusing. So I do want you to know that the email address for each coordinator is listed under the trial, and you can always reach out to them directly and they can talk to you about it if you just want to know more about a study or see if you qualify for something. All right, so now I want to spend a couple minutes talking about the MS Advanced study. And this is the study in which over 500 of you actually agreed to participate and complete surveys every month. And the study is over now, so I'm going to be talking about some of the data from that. So again, thank you to everyone who participated in this. We know that completing these surveys took a lot of time. It wasn't always easy to do this. And we want you to know that by participating, you really enabled us to explore some very interesting and very meaningful research questions, which we are still looking at today. And what was interesting and unique about the MS Advanced study, which again, this study has ended, but this study was really about you and the opportunity for you to tell us how your MS symptoms affect you on a daily or a monthly basis. So by doing these surveys, you enabled us to really take a deep dive into understanding your symptoms in a very meaningful way. So now I want to take a deep dive together into some of the data that we looked at and some of the analyses that we did in this study. So this is a snapshot. This is just an example of the types of reports that we would look at on the back end on a monthly basis as you all were completing the study. There was a lot of work on our team here in looking at these reports every month. And these are the responses to a questionnaire called the PHQ-9. And this is a measure of depression that you would report to us. So again, this is just one snapshot of the data. And we truly looked at all of the responses that came in, and we spent a lot of time on it. And what I love about this is because there was so much data that we gathered through this study that over the last 4 years, we've actually had medical students who decide to spend their entire summer with us looking at this data and exploring research questions that we are all interested in. So I want to show you 2 posters from some of our previous summer research students and explain what they found. All right, now this is a lot to look at, so I'm going to help us go through it. This poster, this is a project that our very first population health scholar, Erica Menino, completed. And this is really detailed. This is a whole project worth of information. So for the purpose of our discussion, I'm going to focus on the purpose of the project and what Erica was able to conclude. So Erica understood that depression is the most common symptom in MS, and she wanted to explore that more. So the purpose of her project was to understand how other symptoms, such as degree of disability, cognitive status, or time since diagnosis, so other factors, I should say, how might those factors correlate with depression, because it is so widespread and it affects everyone differently. So she wanted to understand, using the data that we have, if there are some patterns that we could identify to help us address this symptom better or in a different way. So what did she find? Well, interestingly, she found that none of the outcomes from the questionnaires could really predict or explain depression differently, except for socioeconomic status, which is very interesting. And what I like about this example is that it shows how valuable research data is, even if you don't always answer the question we were first interested in. So when you, on the back end, when you have a really dedicated group of thorough researchers and people looking at this, there's always something you can find from data as large as the MS Advanced study. So that's why I wanted to share this example with you, because it's okay if we don't always answer the original question that we sought out to look at. And what we were able to conclude through Erica's research is that depression is so complex, it affects everybody differently, which helps explain why it's so important that we have a mental health professional as part of our team. And as many of you know now, we have a social worker, Kim Foster, who works with us. So I really like this example because it shows how data can be used to actually support meaningful changes in a practice like ours. So after Erica, our next population health scholar, Sahaj, wanted to look at the same data, but from a different angle. So he wanted to understand if there are different types of conclusions that can be drawn when we look at the data through the lens of specifically our Black and African American patients. And this is really important for many reasons. And as Dr. Shin mentioned in the beginning, we know that our minority populations are not always well represented in research and clinical trials. So it's really important to understand if we can draw conclusions about a larger group of the population from a smaller group of people who decided to participate in a clinical trial. So again, Sahaj wanted to understand how well these questionnaires, which we call PROs, those are patient-reported outcomes. Those are the ones you spend a lot of time answering, and sometimes they're confusing. But he wanted to understand how well the PROs can explain outcomes specifically in our Black and African American patients. And in the research world, we call this validation. And that's the process of gathering and analyzing data to be able to say that the questionnaires we're using is actually a good or legitimate way to measure something. So what did he find? Well, Sahaj's research was able to show that the quality of life and disability questionnaires we used were just as reliable as patients' own self-reported health in our Black and African American patients at Georgetown. And it's important to keep in mind that the results only pertain to our patient population. This was not a large enough study to pertain to the entire Black or African American population as a whole, but it did hold up for our patients. And this is really important for future research because it means we think we can rely on the PRO data that we collect for Black and African American patients. And that's the best part about research, is that everything that we do is laying the foundation for more studies and more work to be done. So I'm really happy that you all are here today to learn about this. And on that note, I am going to introduce you to Maggie Lana, our population health scholar who's been working with us since this summer. And many of you have been kind enough to talk to her and our other research student, Myra, over the phone. So I wanted to say thank you all for doing that. And I'm going to pass it over to Maggie now.
Hi, everyone. I hope you can hear me. So my name is Maggie Lana. I'm a med school student at Georgetown, and I've been working with Dr. Tornatori, Lexi, and Myra, like Lexi just said. Some of you might recognize my name if we've spoken over the phone, and I did want to thank each and every one of you who participated in the study and spoke with me and shared your story. I'm extremely grateful for that. So the title of my research project, it's a little bit long, it's a mouthful, The Analysis of Impact of Social Distancing During the COVID-19 Pandemic on Longitudinal Severity of Depression in MS Patients, a single site center analysis. So for a little background, there is consistent evidence of higher prevalence of depression in people with MS. And the CDC has stated that social distancing during the COVID-19 pandemic has increased the mental health needs in the US. And because patients with MS might be self-isolating more than others because of their increased risk of infection, as well as many other factors, it is crucial that we understand how social distancing has been affecting their mental well-being so that we as a team can provide more targeted, integrated, and proactive comprehensive care to these patients during times of social isolation. Quarantine started back in March, and we didn't know for how long that was going to be. And now it is November, and it still could go on for months, or something similar like this could happen in the future. That's why this research is extremely important. So our primary objective is to analyze the impact of social distancing during the COVID-19 pandemic on the severity of depression in MedStar MS Center patients. We hypothesized that there would be an increase in severity of depression in MedStar MS Center patients. So continuing on with the methods, our study design is a non-intervention observational study. It's basically a new addition to the MS Advanced study that Lexi was just talking about that was performed in 2017, which, as she said, it was a group of patients participated in a longitudinal study that was assessing the quality of life in patients with MS. So we kind of got a smaller subgroup of those patients who had completed a couple baseline surveys, and we chose the NeuroQual, which is quality of life in patients with neurological disorders, and the PHQ-9 standard depression survey. And with that, we ended up with 197 patients. For our exclusion criteria, our exclusion criteria were patients who were cognitively impaired, patients who were unable to give consent, no longer a patient at MedStar, were not willing to participate, or had passed away. So what we did was a one-time phone call interview, provided there was verbal consent, and it took about 30 minutes, where we completed the NeuroQual. And it was 3 specific subsections of the NeuroQual, actually. It was anxiety, depression, and fatigue. There's been a lot of evidence and research out there that these 3 are interconnected, which is why we chose these 3. Then the PHQ-9, and then I came up with a historical questionnaire that was approved by the IRB to get a better understanding of each patient's particular experience throughout quarantine. So I transcribed all of that into a secure Georgetown box. If any of the patients screened positive for suicidal ideation or thoughts, I contacted Dr. Tornatori immediately. And then for the statistical methods, which we're now just getting into because I recently finished all the phone calls, but we're completing paired sample t-tests of all the data. And we want to look at the historical questionnaire responses and see if we can find any content there. So out of the 197 patients, we were able to get in touch with 115 patients. This is a very busy slide. What I just wanted to show you here is that when comparing, we did paired sample t-tests for the PHQ-9 scores and also for the NeuroQoL scores, a cumulative score, where we added the score for anxiety, depression, and fatigue. And we didn't find the results in the PHQ-9 to be statistically significant, or the difference between them. However, for the NeuroQoL data, we did find a p-value that was that showed that the results or the scores from the advanced study compared to now, these showed to be statistically significant. So from there, we decided to dive a little bit deeper and divide our patients into different subgroups and see what we could find there. So we divided our patients into females, males, patients under 55 years old, and patients who are 55 years or older. And we were comparing, among these subgroups, we're comparing not females comparing to males, but among females, data from the advanced study compared to COVID-19. And we didn't find any results here to be statistically significant. However, when looking at the NeuroQoL data, cumulative data, we did actually find the results among females and among patients who are 55 years or older, that data to be, those results to be statistically significant. And this was very interesting to see. We actually found something similar when comparing race. We found the results among patients who are white to be statistically significant. What's interesting to see though is that the score, the NeuroQoL score actually went down. So a lower score means less severity of depression. In a way, this makes sense. I did speak to a lot of patients who reported being more comfortable in their homes. They didn't have to spend as much energy or time commuting to different places or to see a friend. Now they were communicating with people over Zoom, just like everyone else. They were working from home, just like everyone else. They could spend more time at home with their families where they're comfortable. So that does make sense. But I did speak to a lot of patients, and you can see here, well, first of all, our minority groups, so patients who are Black or African American or a race other than Black or African American or white, they first of all show a higher NeuroQoL score in the advanced scores and the COVID-19 scores. So in 2017 and 2020, they still show a higher NeuroQoL score than patients who are white. But I did want to note here that patients who are not who are a race other than Black or African American or white showed an increase in their NeuroQoL scores. So they did show what, in a way, what we were hypothesizing to see, although these results aren't statistically significant. We do see an increase in the NeuroQoL score, so an increase in severity of depression. And I wanted to make a note of that because we're not disregarding any conversations. I want you to know that we're not disregarding any conversations that I had with you or with any patients. I did also talk to a lot of patients who said that they were struggling more or more frustrated, anxious, more depressed. So there's still a lot more work that we need to do. I still want to take a better look at the historical questionnaire and see what we can find there. But I did create a little word map to show you responses that I got from one of the questions, which was, what were your biggest concerns throughout quarantine? And this word map really stuck with me. We have, the bigger the word, the more times it was repeated. So we have words like getting COVID, worried, family, job, concerned, health, uncertainty, social, anxiety. So we still need to look a lot deeper into this and understand that, yes, there are patients who maybe are more comfortable at home, but there are still patients who have been struggling through quarantine. And that's what we are here to look into and see what we can do about that. So some limitations to the study. The phone call interviews were difficult for many patients. They would have preferred an online questionnaire, something to look at and take their own time instead of a 30-minute, in a sort of way, quick interview. A lot of patients did not like the PHQ-9 survey. We had 4 option answers for them, and a lot of patients mentioned it jumped too much from not at all to several days. And then the collection of data took 4 months. So a lot has happened throughout these 4 months, whether that be change in social distancing guidelines. Some patients might have gotten more used to quarantining or more frustrated with it. So that is something that we need to take into account. What we want to do now is still look into those historical questionnaires, but also do a paired sample t-test with patients who have been taking antidepressants throughout all of quarantine and those who have not been taking any antidepressants throughout quarantine, and see what we can find there. So to conclude, and this is a very up in the air conclusion, but it's just what we found right now, that there was less severity of depression in female patients, white patients, and patients 55 years or older of MS or MS center during social distancing in the COVID-19 pandemic. Our future goals eventually, when we finish this up, is to still support those patients with MS who did report higher severity of depression during the COVID-19 pandemic, whether that be reallocating community resources by social workers with community healthcare workers, telemedicine counselors, and hopefully try to help. So that wraps it up, and these are my acknowledgements. Thank you very much.
Thank you, Maggie. That was terrific, really terrific. I think, it really shows that, we don't always know what the results are going to be. And I think it is important just to kind of clarify some points that there was still a lot of depression in patients who are out there. There was just a very small group that seemed to do a little bit better during this period. And it may be those folks that have the opportunity to work from home. They're less stressed out about it, but there still is a very significant group of patients who still score pretty highly on depression scales amongst all our patients. So we recognize this, but it's teaching us something about a small group of patients. So wonderful work. I know you spent a lot of time talking to patients, like a huge number of patients, and an incredible effort on your part and Myra's part. So thank you so much for doing that. And hopefully you'll stick around and continue the work as you were talking about. That would be wonderful.
Thank you.
So I think we're going to the break now. So the break will go until 10:10. I don't know if Dr. Shin, if you want to jump in, if you have any other comments.
Sure. Well, as you mentioned, we're going to move into a break. Let me see if I can get this up. Now, we are, just to answer some questions, the main splash page that you landed on, as I mentioned, has a number of different links. It's basically a live exhibit hall for those of you who would like to explore that. I also would like to emphasize, I know people have been using the different functionality, which has been awesome. But if you do have a question, especially about one of these presentations, if you can enter that into the Q&A section, then if we're not able to get to that live, we'll try to tackle that at the Q&A session at the end. The chat is a little bit trickier just because it's a little bit messier. So if you do have questions about our presentations, I encourage you to use the Q&A function. I am going to show, there is a video from one of our sponsors that I'm going to play now for a few minutes. Please, obviously take a break, but also check out the exhibit hall as well. And then as Dr. Tornatore mentioned, our next talk will actually start at 10:10, but again, stay tuned for this video.
Uplizna is an immunoglobulin G1 or IgG1 monoclonal antibody that is humanized, afucosylated, and binds specifically to CD19 for efficient B-cell depletion. While the precise mechanism by which inebilizumab CDON exerts its therapeutic effects is unknown, preclinical and clinical evidence of B-cell depletion suggest potential activity in aquaporin 4 positive neuromyelitis optica spectrum disorder, or NMOSD. CD19 is present on pre-B cells, mature B cells, plasmablasts, and some plasma cells that contribute to NMOSD's multi-mechanistic pathology through autoantibody production, cytokine-chemokine secretion, antigen presentation, and T-cell interactions. Uplizna bound to CD19 surface antigen enables antibody-dependent cellular cytolysis, ADCC, that lowered peripheral B cell counts after 8 days and allowed 100% of patients to experience B cell reductions below the lower limit of normal by 4 weeks. The engineering of Uplizna contributes to its differentiated mechanistic and clinical profile, efficient depletion of CD19 positive B cells through enhanced ADCC, low rates of drug-drug interactions, low rates of anti-drug antibody generation, low rates of infusion reactions, 6-month maintenance dosing, and depletion of the spectrum of CD19 positive B cells that activate autoimmune and inflammatory disease mechanisms. Uplizna is FDA approved for use in adults with AQP4 antibody positive NMOSD.
Okay, I guess we'll go ahead and get started. So our next presenter is well known to the audience. This is Dr. Erica Mitchell, who is a nurse practitioner at the MS Center for, dare I say it, almost 2 decades. Not quite, not quite. But Erica has been, a wonderful, wonderful an integral part of the MS Center from the beginning. And during her time, she got her doctoral degree. We're very, very proud. There's very few nurse practitioners that have a DNP categorization. So we're very, very proud. Susan Stewart, who was also in the center, also achieved that. Just wonderful. And Erica now is going to kind of segue a little bit from what Maggie talked about with the depression and COVID, but is going to talk to us about COVID and MS in more broader terms. So the floor is yours. Thank you, Erica.
Thank you. Thank you. Thank you. All right. So I'm going to attempt to, good morning, everybody, first of all. I'm going to attempt to share my screen here. Okay. Bear with me one moment. Okay. I hope everybody can see me and everybody can hear me. So again, thank you for the introduction, Dr. Tornatori. This is kind of an odd year. I really actually enjoy looking out and seeing everybody's lovely faces. But hopefully next year we'll be able to reconvene in a live format. So my talk today is really to give some information to you guys about MS in the COVID era. The objectives for this morning's talk is talk a little bit about what is COVID-19, common symptoms that are associated with it, discuss some of the implications for multiple sclerosis, talk a little bit about the COVID-MS registry, treatments and vaccinations, where we stand with that, and just review with some tips and recommendations. So first and foremost, what is COVID-19? So I'm sure this is not new to anybody. If you have your television on for the past 7 months, I'm sure this is all you hear about. But so there are many types. I have to move myself. Hang on. All I can see is myself. So there are many types of human coronaviruses. They are not new. They've been around for a long time. And actually, the common cold is actually a type of coronavirus. So a lot of these viruses, they'll cause mild upper respiratory tract illnesses. But the COVID-19, also known as SARS-CoV-2, is what we call a novel virus. So it's new to humans. So this particular strain of the coronavirus has not been previously seen in humans. COVID-19 emerged in China around November, December of 2019. Global cases as of about 15 minutes ago, I just checked the Johns Hopkins global map, have surpassed 49 million. It's actually, I think, 49.6 million. And I'm guessing probably by the end of the weekend, we'll pass the 50 million worldwide mark. And in the US alone, there's over 9.7 million cases. Again, if you ever go, I put the link here. It's kind of fascinating and terrifying kind of at the same time, but it changes even since yesterday. Okay. Oops, wrong way. So how is COVID-19 transmitted? We know that the virus is spread through droplets and airborne particles that are formed when a person who is infected with the virus coughs, sneezes, sings, talks, breathes. This can be direct or indirect contact. So hopefully people aren't sneezing in your face, but that is depicted in picture 1. But somebody could cough into their hand, shake your hand, and then you touch your nose, mouth, eyes. The respiratory particles can also be on desks, doorknobs, things like that. And if you touch them and touch, again, these mucous membranes, it can transmit the virus. So CDC has come out, they had some guidelines. So in order to catch the virus, you have to have close contact with an infected individual. And they recently changed about a week and a half ago their definition of close contact. So we all know it needs to be within about 6 feet of an infected individual. But the time frame, they said in the past, you had to be 15 minutes exposure. But now that actual 15 minutes exposure is over a 24-hour period. So you could have 5 minutes, 5 minutes, 5 minutes in a 24-hour period, and that can increase your risk of transmission. So how does the COVID virus attack the body? So the virus enters the body through the mucous membranes, mouth, nose, eyes. And if you see, there's a little picture in the top right corner, and that is a picture of the coronavirus. And you see the little red spikes. There's something that's called a spike protein. And the spike protein, once the virus enters the body, attaches to your healthy cells via something called the ACE2 receptor. And the ACE2 receptor is usually, it's commonly seen, it works in your body to regulate blood pressure. And once the spike protein attaches to a healthy cell, there's some chemical reactions that happen, and the virus actually fuses to your healthy cell and is able to transmit its genetic material or RNA into the healthy cell. Once that material is in the cell, the virus kind of hijacks your healthy cell function, and the infected cell is now programmed to create more virus. So symptoms of COVID. As we've gone through the pandemic, we have been adding more symptoms to this list. But typically, a patient can have fever, chills, cough, shortness of breath or difficulty breathing, fatigue, muscle body aches, headache. What kind of sets us apart, a lot of patients are like, what's the difference between the flu and COVID? Most of the times I have not seen anybody with the flu lose their sense of taste or smell. So that can be one way to differentiate between the two. Patients can have a sore throat, congestion, runny nose, nausea, vomiting, or diarrhea. And also patients can be asymptomatic. So you can have an infected individual who exhibits no symptoms. So talking about MS and COVID, I have received calls from people who are concerned that having MS increases their risk for contracting COVID. So the current evidence right now that we have shows that simply having a diagnosis of MS does not make you more likely to develop COVID-19 or to become more severely ill or die from the infection any more than the general population. Now, with that being said, there are certain risk factors that can increase your risk for more severe disease course. And these include having an underlying comorbid disease such as diabetes, lung disease, asthma, COPD, heart disease, and obesity. We know that an older population over the age of 60 can increase your risk for more severe disease, as well as having impaired mobility, smoking, and higher levels of disability. So the EDSS of 6, greater than 6, means that you require some sort of a walking aid. So again, I want to reiterate that having MS alone does not mean that you're more likely to contract COVID, does not mean that you're more likely to have a more serious course or die from COVID. It does not mean that you should stop your disease modifying therapy, and it does not mean that you should not start a new disease modifying therapy if that is the treatment plan discussed with your provider. It does mean that you should contact your provider if you're having concerning symptoms. We can talk it out and say, hey, Erica, I'm feeling this, and this. What do you think? Having MS alone, it does mean that you should continue your disease modifying therapy and continue to practice CDC recommendations to decrease your chance of exposure. And I'll go over some of those at the end with the tips. So I want to discuss a little bit something called the COVID-MS registry. So this is kind of an information hub. Again, this is a novel new coronavirus. We are gathering information. We're learning constantly. And one way is through this registry. This is a joint effort between the National MS Society, the Consortium of MS Centers, and the Multiple Sclerosis Society of Canada. So it's kind of a North American registry. And the goal of this is to capture information on the outcomes of people with MS and other CNS demyelinating diseases. So this is not just MS. This includes individuals with the NMO spectrum disorder that Dr. Osborne had talked about, as well as MOG antibody disease, who have developed the COVID-19 virus. So this is current as of yesterday. Again, all of the COVID data, and that was something that was a little difficult when developing this presentation, is the data changes. So I was constantly going and updating numbers. I just wanted to present the most current data, and this is as of about 10 o'clock last night. So the COVID-MS registry, you can see on the left, the graph on the left, there have been roughly 1,255 confirmed MS patients in this registry. The other numbers there are demyelinating diseases. So we're looking at, in this particular registry, about 1,300 patients. So talking about outcomes, recovered or recovering, I just want to point out that that's really, it's close to 90% of the MS patients who were listed in this registry, either fully recovered or currently recovering. There were reported 58 deaths, which is about 4% of the reported cases. And around the same percentage never developed symptoms at all. So looking into the registry, and this is not the entire list, it would have taken a lot of slides and I would have had to make the font really small, but just kind of cherry picked some of the medications that patients in this registry were on when they were diagnosed with COVID. And I want to point out, and I don't know if you can see my little arrow, but the majority of the patients who died in the registry, they were not on any MS therapy at all. So I know that there is some concern about some of the B-cell depleting therapies, which are highlighted. There are a few more deaths in patients who are on these therapies. But again, these are very small numbers. This is registry data. It's really not enough to make an informed decision. So what do we know? We know what we think we know is that interferons are unlikely to impact negatively on the severity of COVID. And current evidence is pointing that people who are on most of the oral medications do not have an increased risk of a more severe form or course of COVID or death. So going back to the B-cell depleting therapies, they may be linked to an increased chance of being admitted to the hospital requiring intensive care treatment during COVID-19, but the evidence is really unclear. It's not strong enough to make that assumption. And really more data is needed for some of these other therapies such as Tysabri, Lemtrada, and Mavenclad to really make any clear, informed assessment of their safety. And I wanted to point out, so the COVID-MS registry is really based in North America, but there was also a French registry that collected some of the similar data called COVACEP. And I just wanted to, I found this a little comforting that their data really seemed to mirror what we're seeing with the COVID-MS registry. And my takeaway point is that the higher severity cases of COVID, which had the higher deaths and the more serious forms or courses of COVID, were in patients who were not on a disease-modifying therapy. So again, you know, we want you to continue your therapies. If you are slated to start a new therapy, we want you to start a new therapy. So moving on to treatments, there's one approved, FDA approved treatment for COVID at this point. It was approved on October 22nd. And it's an antiviral medication called remdesivir. And they looked at, there were 3 different studies that I looked at regarding this treatment. And one of the trials, it had looked at over 1,000 hospitalized patients, and they had mild, moderate, or severe COVID, who either about 50-50 received the antiviral medication or placebo, along with a standard of care treatment. In this study, they found that the administration of this antiviral did reduce recovery time from 15 days to 10 days. That was statistically significant. And they defined in this study recovery as either being discharged from the hospital or being hospitalized and not requiring supplemental oxygen. They also looked at, in another study, the length of therapy. Some patients were given 5 days of the antiviral, some given 10 days, and they really didn't see any difference in efficacy in the longer course of the antiviral therapy. Again, with any medication, there are multiple side effects with this. The 2 most concerning is being anaphylactic reactions or allergic reactions and increase in liver functions. And, you know, there's a lot of research going on trying to find treatments for coronavirus. And one website I looked at, so there's actually 319 treatments currently under investigation in some fashion. looking, and some of those are the disease modifying therapies that we use in MS, which I found interesting. So dimethyl fumarate, which is Tecfidera, and this is purely bench science. It was actually shown to inhibit growth of COVID in a test tube. Not quite there for human use, but that is an interesting study. So another trial that I found was looking at inhaled interferon to decrease the severe respiratory symptoms associated with COVID, and it also improved recovery time. And that was actually based out of, as a UK-based company. We actually don't have inhaled interferon available in the United States. Third trial that I found was looking at fingolimod, or Gilenya, with ventilated support for COVID-19 related acute respiratory distress syndrome, and in decreasing the severity and occurrence of that. Moving on to vaccinations, and this is current information as of the 29th of October. There's this very cool website that I found, and the link is down at the bottom. It's called COVID-19vaccinetracker.org, and you can fall down a rabbit hole on this website. It's kind of fascinating. There are about 214 vaccinations are currently in some phase of development. 39, according to this vaccine tracker, are in clinical testing, which actually that has gone up. The WHO website says there's 47 in some phase of clinical trials. So it's on the way. Everybody, a vaccination is on the way. It's just going to take time. Typically, it takes about 10 years to bring a vaccination to market, and the estimations are around 12 to 18 months, they're thinking, for coronavirus. So this brings me to kind of the last portion of the lecture is tips and recommendations. And I'm sure everybody here has heard this over and over again, but there are things that measures you can take to try to protect yourself from contracting the virus. Number one is to wash your hands frequently. You want to wash for 20 seconds or longer with soap and water. An alternative, if you do not have access to that, is using an alcohol-based hand sanitizer that has at least 60% alcohol. You want to keep your distance from others. You can tell this is a British slide because they're using 1 meter, but at roughly 6 feet apart at all times. You want to avoid touching your lips, eyes, nose. I didn't realize until we had to start wearing our masks full time how much I actually have my hands up to my face. It's kind of alarming. Again, you want to use a face mask when you are having to go out and be around other people. And stay at home if you feel unwell. Don't take a chance to infect other people. And stay informed as much as, I think there's kind of been this, it's either the election or COVID. But it is important to stay informed because the information is constantly changing. The National Multiple Sclerosis Society, I think, does a very good job of keeping their website updated as far as COVID and MS are concerned. And more tips and recommendations that kind of curtail especially to our MS population. We really recommend that you should continue, if you're on your disease modifying therapy, continue with your treatment unless you're advised for some reason to stop by your treating clinician. If you do develop symptoms of COVID-19 or you test positive for the infection, let us know. Number one, we can discuss your therapy if there are any changes that do need to be made, and we can collect your information and add it to this MS registry so we can continue to learn about outcomes. So that is really important. Get your flu vaccination this year. Anything you can do to protect yourself, because it is possible to be co-infected with the flu and the coronavirus, which would probably not be a very fun time. Another thing that you can do is register for contact tracing. So DC, Virginia, and Maryland all have apps that help contact tracing. So this is a good way if you have a potential exposure, you would be contacted. So I really encourage you to sign up for one of these programs. And thank you. That leads me to the end of my talk. I hope you learned something.
That was great, Erica. Thank you so much. Really, really terrific overview of COVID, which is, you say, constantly changing. And with that, it's my pleasure to introduce Deborah Riley. Deborah's CV is on the website, but it's very impressive. Deb has been at Georgetown since 2018, and she is with the Lombardi Arts and Humanities program. But Deb has a long history. She's been a touring artist and educator, and has performed throughout Europe and US as a choreographer, and has choreographed over 40 original works for her own company, the Deborah Riley Dance Projects. She was an artist in residence at DC's Dance Place since 1988, and then retired as the executive co-director in 2017. And in 2016, she was honored with the Pola Narinsky Award for Lifetime Achievement in Dance. And she's just a wonderful, wonderful asset. Some of you have probably interacted with her in the waiting room. She does the stretch breaks and noontime yoga. This was pre-COVID. Now we can't do that. And Deb also is the lead teacher for the Movement for MS program, which I think some of you are part of, and that is now online. And I know it's, and with Erica, has really expanded out the number of patients who are able to participate in that. So Deb, a real pleasure, and I'm going to hand it over to you.
Well, good morning. Thank you very much, Dr. Tornatore. And I'm going to be visible here in just a minute to everybody with the help of Derek, I hope. I'll just talk to you until you can see me. Thank you to my friends who are going to make this possible for me to see. All right. I hope that you are seeing me.
We can see you, Deborah.
Great. All right. Thank you so much. Thanks for that help. Good morning, everybody. Thank you for that introduction, Dr. Tornatore. A big thank you to Dr. Tornatore, Dr. Shin, and Erica for supporting our Movement for MS class. As Dr. T mentioned, we are now virtual. So everyone can join our class. You don't have to travel to get to us. And I'm here today to do a little movement to you, to tell you about our class if you haven't heard about it. I think one of the most important things about our class is gathering together, and relationship to what Lexi was presenting in research today about depression. This ability to gather in community and to have fun together has been really an enriching experience, I think, for all of our dancers. So I encourage you to join us. We dance, we express ourselves, we share, and we enjoy each other's company coming together. Today, I'm going to give you a little taste of what we do. And before I do that, I do want to give a shout out and a big thank you to Julia Langley, who's the director of the Georgetown Lombardi Arts and Humanities program. And we are under the program at the Arts and Humanities. So thank you, Julia. As we move today, most important, stay safe, be comfortable in your movement. This is your dance. So please be comfortable in doing your dance. And what else do we need to go? I'm just doing my screen here. Yeah, let's arrive in our bodies. Let's arrive in our bodies. Let's yawn. Just take a nice big yawn and a stretch any way you want. Feels so good to stretch. Oh, just move and yawn and stretch any way you want. Yes. Oh, good. Yes. Let's flutter your hands like they're little hummingbirds all around you. And then let your arms wiggle. I'm going to drop my arms a little bit and wiggle in your shoulders and wiggle in your spine. Just get a little happy bubble of wiggling all the way down to your hips and your tail, and maybe wiggle your legs, wiggle your arms, just very gentle, little bubbly energy. And breathe. Yes. Great. Let's place our hands right over our heart center. I have one hand and then the other on top of it. And let's just take a few nice full breaths into our heart center. So here we go. Breathing in slowly, right underneath your heart. Breathing out slowly, relaxing your shoulders. Nice. Breathing in, lifting underneath your heart. Breathing out, relaxing all the way down the spine to your feet. Let's do it one more time. Breathing in slowly, lifting the heart, letting it swell. Breathing out, relaxing down to your feet. And I like to do this. I like to connect to you, and maybe you can connect to me and everyone here through your breath. So let's try this. Breathe into your heart. And as you breathe out, send your good energy out to everybody here by reaching. Nice. Breathe into your heart. Breathe out and connect. I feel you connecting to me. Thank you. One more time. Breathe in and breathe out and connect to each other. So important right now. Great. Okay. Thank you. Let's do a little stretching. Just to remember, be safe, make any kind of accommodation. I have to change my camera here. Welcome to my home, my dance studio today. And I have some music that I'm going to put on. Just follow along. Make any kind of accommodation or change. Do your dance. What's your dance today? All right, let's get started. And my music is over here. So I just will turn this on. Let's just settle in. Great. Let's start with our shoulders. Just some nice rolling of your shoulders, very gentle. Relax in the neck. Oh, a little bit more, it feels good. Nice. Okay, let's take one arm, just stretch. Now you might only stretch here, that's fine, or stretch long. Really reach over that side. Bring your arm down. Let's stretch the other side. Reach long. Bring your arm down. Let's sweep two arms up. Inhale, sweep. Exhale, palms down. And again, inhale, sweep up. Exhale. It feels so good to stretch. One more time. Inhale. And exhale. Excellent, excellent. Let's stretch our hand. So palm forward and just give a little resistance, pushing your palm and resisting with your other hand. Open the palm. Breathing. Let's change hands. The other hand, pull the fingers back. My elbow is soft. Nice. The back of the wrists. Just reach down, stretch the back of the wrists. Breathe in. Breathe out. Nice. Let's stretch our leg. I'm going to extend my leg out. Hold your chair. Maybe your foot is down lower to the floor. Lengthen and reach through the heel. Pull your toes back. Bring your foot down. Try the other foot. Reach as if you have a light at the bottom of your foot shining forward. Reach, 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 reach. Nice. Bring your foot down. A little pat on your shoulders and crossing my arms, or you can pat your arms. Rest your hands, and let's turn in your shoulders. A little twisting slowly side to side. Just take your eyes, your shoulders, around the rib cage, turning. Let's do 2 more. And 1 more turning. And come back. Great. Let's lift our heel and down, and lift the other heel and down. I'm mimicking with my hand what my foot is doing. Lift your heel and down, off the floor, toes on the floor. Nice. All right. Let's take the legs wide, or leave them together, but if you want to take your legs wide, hold your chair, lift and bend side. And then if you want to stretch your arm, you could do that. Nice side bend. Come back up and side bend to the other side. Nice, very nice. Thank you. All right. Thank you so much. All right, a little stretching to get into our bodies. In our class, sometimes we always check in with each other with how you're feeling. And since this is a creative class, we create things together, we express ourselves. I'm going to ask you, but I'll tell you what I mean by that. So I'm going to say how I feel today in 1 word, and then I'm going to do some movement. So I feel optimistic. That's how I feel today. And join me and say that with me. I feel optimistic. That's my movement. Now I'm going to ask you the same question to say, I feel, and then answer that in your word and try to make a little movement. Okay, on 3. Here we go. 1, 2, 3. I feel. Okay, very nice. But I didn't quite hear everybody. So let's do it 1 more time. Okay, on 3. I'm feeling. 1, 2, 3. I feel. And we all feel different, right? That's the nature of humans. We feel different, but it's part of what we do to express ourselves in the class. All right, let's do a little bit of a quicker movement experience together. This is a little patterning. If you don't get the patterning, don't worry about it. Just have fun and enjoy the rhythm. And what we're going to do is we're going to learn a little choreography, and then there's a break where I encourage you to do your own thing. Find your groove, find your movement and expression, and then we'll come back and do the choreography together. All right. All right, let's see. I have my music back here. All right, let's start with the heel lifting. Yeah, a little stretching of our feet. Make sure you go to the big toe and the middle toes and not roll out to the side of the ankle. Just give toes reaching into the floor. All right, now just try and follow along. We're gonna go side, in. I'm tapping my foot. I'm crossing my arms. I'm gonna tap twice. Yeah, it's a little bit of a brain teaser. Let's march slowly and lift our arms. And then come in, curling, and open, and close. And let's go cross, 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 shake and wiggle, sprinkle, cross, 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 around. Let's go back to the step. Little pattern, open and close. Nice. Okay, you're getting the hang of it. All right, now get ready to do your own thing. Find your rhythm. This is a Cuban composer who lives in Havana. We could all imagine that's where we are, dancing in the street. Look at the space around you. Let's come back for our choreography. Little tap. Nicely done. Great. Just have fun with the rhythm. All right, let's go open. And a little close in. And open. Let your spine move. Let's cross. Cross. Sprinkle around. Again. Cross. Here's our step out to the side. Good. Nice, everybody. Yeah. All right, get ready to do your own thing again. How about shoulders? Can you move in your shoulders? Nice. Can you move in your hips a little bit? Can your elbows move? Can you reach to me? Connect. Yes. Thank you. Thank you so much. All right. A little sample of a quicker dance together. I have one more thing that I'd like to share with you. Usually we make a dance together. We do choreography in collaboration. And in one of the classes recently, and also with another one of my senior classes, we did a class about who we are. And we said, I am, and then just a part of who we are. Maybe not the whole package of who we are, but just a little taste. And so we made a poem, and then we made music. And this is what people had to say. And this is the movement. And I encourage you to say it and try it with me. I am strong. I am wise. I am victorious. I am complex. I am so proud of my power. I am beautiful. I am resilient. This is the sign in ASL for resilience, sorry. Let's do that again. I am strong. I am wise. I am victorious. I am complex. I am so proud of my power. I am beautiful. I am resilient. Now, let's make that a real dance with a little bit of music. And we're going to take some artistic license and just join in to this little, it's like a very positive mantra. All right, I'll say it as we go along. Ready? I am strong. I am strong. I am wise. Thank you for joining me. I am victorious. am complex. I am so proud of my power. I am beautiful. I am resilient. I am. And so are you. All right. Thank you for doing that little positive affirmation dance with me. I am so pleased to be with you here today. I want to give a shout out to Allison Waldman, who is an assistant teacher with me, and Morgan Kulesa, who is our Zoom manager for the class. As I say goodbye and thank you for joining me, I'm going to put up a slide that shows you how to sign up for this class. We have 2 more classes this fall, and then we'll start again in the winter. Join anytime. You can just drop in. It's free. And here is the slide. The class meets on Tuesdays from 1 to 2:15. It's on the Zoom platform. You can call Morgan at that phone number, or you can email her to join us, and then we'll send you the link. Thank you so much for your presence today, for your good heart, and for your creativity. And I look forward to seeing you in our class. Thank you, Bethany, and everyone for making this a wonderful experience for us today.
Thank you so much, Deborah. That was awesome. I actually had been kind of stressed out about this whole session, so moving around actually helped me relax a little, so thank you. I'm going to leave the slide up for just a few more seconds so people who are interested can get the contact information. You can see the email, Morgan Kulesa at georgetown.edu, or there's actually a phone number as well, 202-253-6816, and we'll try to get this information up on the chat as well. So we're up to our second break. So again, just as a reminder, you can have the opportunity to visit the different sponsors, and again, I thank them for all of their support. Our plan is to actually begin with our next session at 11:05. We do have one more quick video to share, and then I'm going to ask you to, be sure to come back and join us at 11:05. So.
Dear MS, it's only been a couple of years and maybe a month or so since we've officially met. But let me just get straight to the point. I don't like you. Actually, I really don't like you. Actually, you're dumb and I hate you. You have caused me so much more mental and emotional trauma than I ever could have imagined. I could go on about all of the silly things you put me through, like the bladder or the gut problems, or the needless depression. You also might have thought it was funny to see me stumble, or to see my hips teeter-totter as I walked. I have had a lot of bitterness and resentment towards you, but really I'm not mad anymore. I'm becoming much more self-aware by traveling more and by doing more with my creative side. And I'm getting to know you, because I find that the more I understand, the more I can advocate for my own health. And even though I don't like you, my sense of inner peace is growing exponentially ever since I finally accepted you for what you are. And I found an inner strength I never knew I had. You're part of me, and I've accepted it. But you're dumb, and I don't like you. Love, Hannah.
Okay, it's 11:05, so why don't we go ahead and get started? It is my distinct pleasure to introduce Dr. Brian Barry for the next talk. I've known Brian for almost 10 years as both a medical student and as a neurology resident, and then as our MS fellow here at Georgetown last year. Brian is extraordinarily bright. I will tell you a story that when Brian was a first-year resident in neurology, there was a standardized test that was given to all the neurology residents throughout the country. And Brian was only 9 months into training, yet he outscored almost 85% of all neurology trainees, including those that were almost done with their training. Very, very bright, as you will see. He is now the director of the MS Center at the Washington Hospital Center, which is the first time we've had somebody at the Washington Hospital Center to care for patients in the downtown area of DC. And so, Brian, the floor is yours. We are absolutely delighted that you're part of our faculty and that you're here today.
Thank you for the kind introduction, Dr. Tornatore, and thank you, Bethany and Dr. Shin, for the invitation to speak today. And really, thank you for everyone who is tuning in out there. As Dr. Tornatore mentioned, I did all of my training in neurology and really medicine at Georgetown, medical school, residency, and fellowship, recently completing fellowship, but really everything I've learned about people with MS has been from you all. So it's really a privilege to be able to have this opportunity to tell you about a very important topic today. And that topic is the changing landscape of disease management in multiple sclerosis. We have some form of this talk probably every year at our patient education days, and that's for a couple of reasons. But one of those reasons is there are always new treatments that are on the horizon. There are always new treatments that are approved, and every year we learn more and more about our existing therapies. And we use this opportunity to update you all about that. So I'll start by talking about some of the MS treatments of the past and move on to the 20 plus therapies that we have for MS today. And I'll end on what I'm sure is going to be a topic of interest for many of you, some of the MS treatments that are in the pipeline and where I see them fitting into the treatment landscape of multiple sclerosis. So I'd like to take this opportunity to kind of plug our MS seminar series coordinated by Drs. Amjad and Dr. Serrano. So those of you who attended the chapter 2 session last month, where it got a sneak preview of some of this material. But really the first 2 centuries of multiple sclerosis therapy were kind of there's more misses than hits. There was no therapy approved until 1993. So those of you who have been in the MS community before 1993, remember the pre-treatment era. And in 1824, it's when the first cases of multiple sclerosis were starting to be documented in the MS literature. Then a few decades later, the famous French neurologist Charcot gave a few famous lectures on multiple sclerosis. And from really there on out, people were looking anywhere high and low for treatments for multiple sclerosis. You know, I can't look down upon them because, you know, I'm sure 100 years from now, they'll look back on our therapies that we have and kind of laugh at us. But in the 1890s, if you had multiple sclerosis, you would be treated probably with some form of a nerve tonic. So this would be, you know, poisons like arsenic, which is rat poison, or strychnine, probably, as you can imagine, did more harm than good for multiple sclerosis. Then really the theme from there on out is any disease that was starting to be treated with rudimentary treatments, those treatments were applied to multiple sclerosis because really then and now we still don't know what the exact cause is for multiple sclerosis. So in the early 1900s, they were trying to, you know, apply syphilis treatments for multiple sclerosis, but these wouldn't be like modern antibiotics. This would be more things like mercury or other heavy metals. Again, very toxic things. In Europe in the early 1900s, they were, you know, sending MS patients to spa baths, which sounds nice until you consider that they were probably filling those spa baths with leeches to do some bloodletting. A few decades later, started getting more modern therapies for things like tuberculosis. The first antibiotics were being developed. And those treatments were applied to multiple sclerosis. And around the same time, there was this idea coming up for the first time that maybe there was a virus that was the cause of multiple sclerosis. And there was even some rudimentary vaccines that were attempted, but unfortunately, none of them ever panned out, and the data was not able to be replicated by other scientists of the time. In the 1940s, really would probably be the first modern MS therapy was developed. So these would be immunoglobulins and ACTH. So these are immunoglobulins, might be familiar to you if you've ever heard of or received IVIG, which is a treatment that we still use occasionally for multiple sclerosis relapses, not so much probably for disease modifying therapy, but the treatment of relapses, we still use immunoglobulins, so antibodies that are pooled together to modify the immune system. Then ACTH is the body's hormone that releases steroids. So steroids, as you all know, are kind of the mainstay of treatment for MS relapses. And we still use ACTH injections for the treatment of relapses. Not disease modifying therapy, as I'll tell you about, but the treatments of the relapses themselves. Then steroids became available. So steroids still to this day are what we use to treat relapses. They were tried for disease modifying therapy, and I'll get a little bit into more about what that means, but never found to be successful in modifying the long-term course of multiple sclerosis. Then finally, in the 80s and then 1993, beta interferons were studied and finally approved for disease-modifying therapy in multiple sclerosis. So from beginning to end, it spans almost 2 centuries. And so really, in the next 3 decades after that, we've had an explosion of MS therapy. So we have over 20 different therapies that are approved and on the market for multiple sclerosis. And they come in many different varieties, many different mechanisms of actions, many different levels of efficacy, many different levels of maybe risk. And then all of them, by and large, have a role and a different kind of patient population that might benefit from each individual therapy. So there's no one best therapy for multiple sclerosis, but by and large, all of these therapies, especially for relapsing multiple sclerosis, patients who have relapses, all of these therapies have a degree of efficacy in those patients. As you go from injectables to orals to infusions, it's a general rule. Again, there are exceptions, but it's a general rule that you get more efficacy. So your ability to prevent relapses, to prevent new MRI changes, and to prevent disability from relapses really increases as you go from injectables to orals to infusions. There are exceptions to that rule. So actually one of the most recently approved drugs for multiple sclerosis, Kesimpta or ofatumumab, is an injectable, but that has more in common in terms of mechanism of action with the anti-CD20 therapies of rituximab and Ocrevus than it does with the glatiramer acetates and interferon betas, the platform therapies that we've had for multiple sclerosis for almost 30 years now. The second class we've had for about 10 years is oral therapies, typically in the middle of efficacy in between injectables and infusions. Again, that's not a hard and fast rule, but a kind of a way of thinking about in terms of like how we kind of pick a therapy. We have several different oral therapies for MS. They vary in terms of their mechanism of action, how often you have to take them. Mavenclad, cladribine, the first one listed here, similar to Lemtrada, one of the infusions, is actually an intermittently dosed therapy where you have 2 courses a year apart, and then for 3 years or maybe even longer afterwards, you do not necessarily need to be treated with any MS medication. Fumarates, another commonly prescribed class of MS medications. The first one that come to market was Tecfidera, but several different other fumarates have come within the last year, including several different generic dimethylfumarates. These are twice-a-day oral medications. Siponimod, fingolimod, ozanimod, and ponesimod are all S1P modulators. Ponesimod is in development, but Gilenya, Mayzent, and Zeposia have all come to market. These are once-a-day medications for multiple sclerosis, and Obagio, teriflunomide, is another once-a-day medication for multiple sclerosis. The infusions, as I mentioned, Lemtrada, is similar to Mavenclad, is 2 rounds spaced out a year apart. Rituximab and Ocrevus would be every 6-month infusions, and Tysabri natalizumab is generally infused every 4 weeks. As I mentioned, in general, as you go from injectables to orals to infusions, we think that we increase our ability to shut down relapses. But maybe there's the potential that you open the door for unintended consequences as you are maybe being more aggressive with modulating the immune system. Potentially you are opening the door for infections. But by and large, what I would say is these therapies are, as a class, very well tolerated. And as long as you're following your provider to have the proper safety measures in place, as a class, they are very safe. How do we pick which one of those 20 therapies for an individual patient? Much of this really depends on where the patient is in their disease course. So we have 3 traditional disease courses for multiple sclerosis, and these have been updated somewhat over the years. And on my next slide, I'll show you maybe how I tend to think about disease course in multiple sclerosis without necessarily using these labels. But relapsing remitting is kind of the most common initial pattern, where you have relapses. So you have a new symptom that comes on, lasts longer than 24 hours before generally improving. Over time, you could have multiple of these relapses, and then the recovery is what we look at. Is that recovery coming back down to the baseline from before the relapse? Very important. And what is the baseline level of symptoms or disability doing in between relapses? Is it a flat line, or is that disability slowly worsening? Are there symptoms that are worsening even between and independent of relapses? Secondary progressive multiple sclerosis on the right starts similarly to relapsing remitting multiple sclerosis, where you have an initial period of relapses followed by a worsening that happens even apart from having relapses. So year by year, the patients might say, my symptoms are getting worse, my walking is slower, my cognition is slower, my bladder is a little bit worse. And it's a different type of treatment strategy that we might look to in these patients versus someone who has purely relapsing disease. Then primary progressive is a third category, where you have typically slow but gradually progressive worsening year by year, both in the progressive phase of secondary progressive multiple sclerosis and primary progressive multiple sclerosis. You can run into the situation where the MRI is looking at essentially the same, but symptoms are worsening year by year. Very important to know, because we pick different therapies depending on the phase of the disease. And as I alluded to, what I tend to think about when I'm seeing a patient with multiple sclerosis is not so much how they started historically, but where they're at that one given time when I'm meeting them in the office. And so these categories, these 1 through 4 are numbers that kind of I arbitrarily assigned. But the 2 questions that I'm trying to answer when I see a patient are, is the patient having relapses? And is the patient having progression? So again, relapses are those inflammatory events where you get new worsening that happens and lasts longer than 24 hours. Typically is a new symptom. You can have symptoms that pre-exist from prior relapses that kind of fluctuate and may worsen for 24 hours. But really for relapses, I'm looking for typically new symptoms that are coming on. And then progression. Independent of relapses, even if you're not having relapses, is there slow worsening that's happening in between relapses? And so category 1 would be maybe the typical relapsing remitting patient, where they're having relapses and no progression. And that would be different from somebody in category 2 who's having both relapses and progression. And that's important to make that distinction, because certain therapies have more evidence to slowing that progression in addition to stopping the relapses. Category 3 would be no relapses and no progression. So these would be people who really are most likely responding very well to disease-modifying therapy. Sometimes you have benign MS, where even apart not on therapy, you don't necessarily have relapses or progression. But the far more common scenario for that I see is someone is just having a very good response to whatever therapy they pick with their provider, and they're not having any progression that you can pick up on their exam every 6 months, every year, how often you see the patient. The fourth category, and this category is really where we're going to be looking to for a lot of the drug development that I'm going to talk about. These are patients who are not having relapses, and yet year by year, they feel they're getting worse. And on the neurologic exam, you can pick up certain things that are worsening year by year. And really, this is a challenging situation for someone who treats multiple sclerosis, because by and large, all of our drugs are very efficacious at slowing down relapses, shutting down MRI changes. But there have only been a few drugs that have been shown to have really been able to slow that progression independent of those relapses. Now, it's important to note that these buckets are not permanent. Patients oftentimes switch phases multiple times during the course of their lifetime with MS. Not uncommon to go from category 2 to category 3 or category 4. And it's really important that we always reevaluate whether or not we're meeting those treatment goals with whatever therapy that the patient is on whenever they come into clinic. So what can we say about our therapies in 2020? And where do we need to improve? So I would say that we have many therapies that are highly effective at preventing relapses and slowing disability. This is really what we're trying to do. We're very good at this. We have 20 different choices that I've shown you that maybe have various degrees of efficacy, but we can always find something, almost always find something that is going to be able to improve the rate of relapses. By that same vein, we're very good at stopping new lesions on MRI. We want to, see year to year when we do MRIs that there's no change that's happening. Some of our therapies now, we're lucky enough to have some efficacy in those progressive phases of disease where there's no relapses, but there may be slow worsening year by year. I can say that by and large, our therapies are very well tolerated in terms of side effects and safe. That's not to say that you can't have side effects on an individual therapy, but almost always we can switch therapies and find another therapy that is tolerable to a patient in terms of side effects. And that goes into my next point. We have 20 plus different therapies at this point, so we have many different choices to tailor our therapy to a patient's preferences, certain tolerability of how much risk they are willing to tolerate, maybe in terms of infections, and what they want, what their goals are for their therapy in multiple sclerosis. What are some areas for improvement? So 20 different therapies, but right now I don't necessarily have a great way of predicting which therapy is right for an individual patient. There are potential side effects, as I alluded to, for really all of our therapies. Therapies don't address existing symptoms. So, you can have a whole talk about symptomatic therapy in multiple sclerosis. We have, almost every symptom in multiple sclerosis can be improved with symptomatic therapy, but that's not really what I'm talking about with disease modifying therapy. We always do both kind of hand in hand. Limited efficacy and choices for the progressive phase of the disease, but I'll show you coming up that we have some therapies on the horizon in addition to what we already have that has efficacy for progressive multiple sclerosis. And of course, therapies are not a cure for MS. So what are some predictions for the fourth decade of MS therapy? I would predict that we're going to get more therapies that slow progression, even if a patient's not having relapses. We are all eagerly anticipating the first therapies that do repair, namely remyelination, undoing damage that's already been done, kind of one of the holy grails of therapy in multiple sclerosis. We're looking for blood tests that might predict which therapy is right for a given patient and when a switch might be necessary. We are in the process of doing clinical trials to figure out when early high efficacy therapy is the right choice. And we're going to get more data about if and when we can stop MS therapy, an open question right now. So here I'm going to end on a discussion of several different therapies that are in the pipeline for multiple sclerosis. And I apologize if I'm not going to cover your favorite, maybe investigational therapy for MS. But what I would say is, what I'm looking for in the drug development pipeline is therapies for progressive MS and therapies for repair. There are going to be more therapies also for relapsing MS, but we have many therapies on the market in that regard. So I've selected some of the ones that are looking to do either treatment for progressive MS or repair. And the first one I've listed here is the Bruton tyrosine kinase inhibitors. There are 4 of these in development, at least 4 in development right now in various stages of clinical trials. Some phase 2 trials have already been completed, and some are going to be completed with phase 3 trials in the next 5 years or so. Very interesting. So there's a theory that progressive MS, why does progression happen even if there are no relapses? So, and why can progression happen even with some of our best, most efficacious therapies for MS? The thought is potentially that there is inflammation that's happening in and around the brain itself that maybe our therapies aren't getting access to. So there's a blood-brain barrier. And for example, one of the prototypical treatments that we have for highly effective treatments for MS is rituximab, which is an antibody. And only 0.1% of the antibody can cross the blood-brain barrier and get into the central nervous system, the brain, the optic nerve, and the spinal cord to shut down the inflammation that may be driving progression. And the BTK inhibitors and several other of these therapies are very small molecules that can get across the blood-brain barrier and get to the areas where we think that damage, that smoldering inflammation is happening in progressive multiple sclerosis. Stay tuned. Hopefully in the coming years, we'll have more of an update of the BTK inhibitors, but a very promising drug class that is in development. I'm not going to highlight all of these, but some of the other ones to look for. Masitinib. Phase 3 data was presented for progressive MS at our international meeting a couple months ago. Very interesting, another small molecule that's weight-based. It's an oral therapy, and this was studied in progressive patients and actually showed a 42% decrease in worsening compared to placebo in progressive MS. Other therapies, alpha-lipoic acid, simvastatin, you may have heard of these. ALA is a supplement. Simvastatin is a cholesterol drug being looked at for progressive MS due to anti-inflammatory properties. Ibudilast has phase 2 trials completed and phase 3 trials that are planned. Several other monoclonal antibodies are being looked at. Elezanumab, temelimab, excuse me, for both relapsing and progressive MS with phase 3 trials being planned. Bexarotene data was presented, phase 2 data was presented, very promising, looking at repair. They looked at MRI lesions and they're changing in some of their characteristics. And this was presented very recently. The problem with bexarotene is it does have some toxicities that are going to prevent it from being pursued further for multiple sclerosis, but it's a very important proof of concept that we are able to do repair with medications and see those changes on MRI. And then finally, opicinumab, another repair drug, very interesting that phase 2 trials are ongoing and are looking to be completed sometime in the next 1 to 2 years. So progressive MS repair are the 2 hot areas that I'm looking at really over the next decade for multiple sclerosis, really kind of as we're getting to our 4th decade of MS therapy, and really looking forward to what these results are going to have in store and looking forward to sharing them with you in future patient education days. So with that, I thank you for your attention, and I'll turn it back over to Dr. Shin.
All right, that was fantastic, Dr. Berry. Thank you so much for that. That actually brings us to the question and answer portion of our session for this morning. And we've actually been trying to tackle Q&A online, live, as much as possible. But many of the questions centered on where is the website for Georgetown, and or especially for people who are perhaps interested in clinical trials to find out more about them or even to participate. So I'm actually going to give everyone a little more time to type in questions for any of the previous sessions. I saw a couple questions coming in for Dr. Berry's talk, and really any of these sessions are fair game. But what I'd like to do is actually turn things over to Derek, who's been our kind of IT wizard and really kind of made this whole morning possible, to kind of help walk us through how to navigate our website. So over to you, Derek.
Hey, good morning, everyone. I hope everyone can hear me. So yes, my name is Derek Hazy. I am a clinical research coordinator in Lexi's office, whose presentation you heard earlier. First off, I just want to say thank you to Dr. Shin and Bethany and all the panelists who've obviously worked so very hard to put this webinar together. Yeah, the amount of care and effort they put into this, it's very evident, and I hope that shows how much they care about all of you, because I know that's something they take pride in. So this morning, I just wanted to share my screen really quick and show you all how to navigate to a few resources that we talked about earlier. So can everyone see my screen, the neurology page? Yeah, cool. All right, so on the neurology page, so Lexi talked about this a little bit earlier. So the website for our department is neurology.georgetown.edu. If you don't remember that, then you can even search, Georgetown Neurology, and it'll usually be the first result in whatever search engine you're using. So that takes you to this page. Now, to speak first to the clinical trials page. So one of the, if you want to know more about clinical trials and who to contact, the best way is to come to this main page here. And then up here in the top, it says clinical trials. So you'll click on this button. And if you scroll down, you can see that we have a number of different diseases and conditions listed, and you'll click on multiple sclerosis. And that brings you to my office's page, which Lexi highlighted earlier. And if you scroll down here, you'll see that we have a number of diseases listed, and we do clinical trials in a number of areas. But for MS, you can see the active trials that our site is doing. So obviously there are tons and tons of clinical trials for multiple sclerosis ongoing at any given time, and not every site will have each trial. So the best way to find out the trials that we're doing is to come to this page, scroll down to the multiple sclerosis menu, and you can see here that we have links to each trial that we have ongoing. You can see that we have 4 right now, and then it also has the contact information. I'm the primary coordinator for 3 of them. So if you have any questions about these, you can email me, or my coworker David is also a coordinator for a lot of our MS studies. And so you can ask him questions as well. And these hyperlinks, as Lexi said earlier, will actually take you to the clinicaltrials.gov page. So every clinical trial that's approved in the US will have a website or a page on the government website for clinical trials, clinicaltrials.gov, and it'll have more information about who's doing the study, what the study entails, so on and so forth. And so those are these hyperlinks here. So if you have any questions, please refer to the clinicaltrials.gov page, and also feel free to email any of us, and we're happy to do our best to answer your questions or put you in touch with the appropriate resources or the appropriate people to answer your questions. So yeah, that's our research page. And then, so going back to the main page, neurology.georgetown.edu, how to get to the MS Center page. The MS Center page is where we post videos, we post event updates, and it's where we'll be posting the videos from this webinar. So we're recording the webinar, we'll be splitting the talks once we have the video file, and then we'll upload each individually to the MS Center page. Now, how you get to that is you come to the neurology website, go to Centers and Services, and you can either use the menu here or scroll down to get to the Multiple Sclerosis and Neuroimmunology Center. So that's us. So come here, and you can see we have a few different resources here. We have obviously the link to Patient Education Day today. We have a video that Erica put together. We have a staff page. So if you ever want to get put a face to a name, you can come here to do that, as well as we'll be updating our events page. And I'm going to be doing a better job of that now that we're utilizing, we're having more events virtually, because for a while it just said, postponed due to COVID. So I'll be updating that, and also information on how to schedule an appointment with central scheduling. And then here, perhaps the most important one, for at least for today, is our video section. And so here, if you want to see the past videos from like Patient Education Day 2019, 2018, here we go, they're loading slowly. You can see that we've uploaded all of these for your reference. And this is where we'll be posting all of the videos from today's webinar as well. And so that's really the meat of it. I just wanted to show everyone, in case you remember neurology.georgetown.edu, but you don't remember the whole link, or you just want to know how to get there from the main page. So that's how you can do it. So just once again, to reiterate, main page, neurology.georgetown.edu, Centers and Services, and then the Multiple Sclerosis and Neuroimmunology Center. I sort of unofficially manage this website. So if you ever had any questions or notice something's incorrect, please send me an email, and I'd be happy to deal with it. And yeah, thank you to Lexi for allowing me to spend so much time on the website and with the MS team. It's really a joy of my job. So with that, unless there are any questions that I can address momentarily, I will turn it back over to Dr. Shin for Q&A.
All right, thank you so much, Derek. Actually, that's super helpful. And I do have to say, you've done an amazing job at revamping our website and making it actually very useful, not just for documenting previous patient education day. You included Erica's COVID-19 video, but also the links to research, because I think really we can't make these advances without the participation of our patient volunteers. So thank you so much, Derek.
Sure, of course.
So I'm going to ask all of our panelists and speakers if they can turn the video back on. And I think, Bethany, maybe if you wanted to start, I'll let Bethany kind of pick out some of the questions to give to our panelists.
Good morning, everyone. Thank you so much for making the time this morning. So the first question, I think I'm going to point out, there were a lot of really good ones, is for Brian. And I guess this is just an important distinction. Someone asked, so if someone is on a statin for cholesterol, would it make sense to discuss switching to simvastatin with their doctor if they have progressive MS? So Dr. Berry, if you could clarify that.
Yeah, it's a great thought. So I think in general, like I would be cautious about necessarily reading too much into the fact that a drug is being studied until efficacy is being shown. But with that said, I mean, obviously simvastatin is approved for high cholesterol. And so I think, in that case, if your doctor who is treating your cholesterol feels that simvastatin would be a good choice for managing your cholesterol, it would be rational to maybe pick that one for your cholesterol based on the fact that it's something that we are looking at for progressive MS. But there have been many drugs that have been looked at in early phase trials that didn't turn out to necessarily show a benefit when the trial data was completed. So I wouldn't necessarily say that would be an urgent switch.
And it looks like someone else asked about atorvastatin versus simvastatin, and I think what you said really just applies across the whole board in terms of statins. I was going to actually sort of mention, even though it's always been great that we talk about sort of promising research, I think your point is excellent that doesn't mean we necessarily would recommend starting. I think of biotin, high dose biotin for a while looked promising, and I know some people started taking it, but we now know a number of trials have demonstrated that high dose biotin is in fact not effective, unfortunately, at treating MS, and actually may interfere with labs, so that's not recommended. And I think even in your talk, opicinumab, as you had on your slide, but as you may know, that anti-LINGO therapy is not going to be, the research has been halted on that product as well. So I think it's a good lesson that there've been a lot of advances, but not everything that looks promising always pans out. So I do think we should be cautious before we, it's good to pay attention to the exciting research, but I don't know if that means that we should always, jump onto that. So.
Dr. Tornatore, I think there is a question that would be good for you to answer in here. It says, and there were several questions to this effect. Please talk about going off MS therapy after a certain age with no progression.
Oh, there is a trial that we're part of called it's a PCORI study, the Patient-Centered Outcome Research Institute, which is sort of like the NIH. And it's a study called the discontinuation study, which we are part of. This is a study that is looking at patients 55 and older who've been stable for 5 years, no relapses, no progression, and no MRI changes. So pretty stable group of patients. And the question is whether in that group of patients, it's safe to take them off medication or not. And we've had several patients at our center be part of that study, and it's randomized. Either people stay on or they go off, and then it's just we follow them. The data for that study is still pending. but I think we will learn more about this over the next couple of months, probably. But there's cautionary tales in this. And this is anecdotal, but there are folks that have stopped medication that meet all of those criteria and have had attacks. There are other folks that have done very well in the study being off medication. And so this is our challenge: is we have people who look like they're doing well, and it makes sense that when they're older, perhaps they should come off medication. And yet, every once in a while, we get burned with somebody who has an attack. And so we have to really be very, very cautious and follow patients very closely in that kind of scenario. It is hard. Ideally, we would like to have better biomarkers for inflammation so that we could check somebody's blood and really tell whether their inflammation is gone before we take them off medication. Right now, we're kind of doing it by the seat of our pants. It probably does make sense once people get to a certain age, and we don't know exactly what that age is, to probably use less of the medications. But again, we need markers. We need better roadmaps for this. We've had patients in their 70s have attacks. And so if we've learned anything about MS, is that it humbles us, that we're not really as smart as we think we are. And so at this point, I would recommend to people that it's a conversation you have to have with whoever is taking care of you. There's no hard and fast rules. And that there is, if you do choose to come off medication, it's really important that you'll be followed really closely with scans and exams to make sure that there's not any downward sliding that can happen, rather insidious, as Dr. Barry talked about. So hard question. Hopefully we'll get better clarity on this over the next couple of years.
All right, there was a question, this kind of ties back maybe to some of the experimental stuff. Somebody asked a question about Relin, which is, if you've been following the research, there is a molecule that in mouse models of MS, so EAE, may help to reduce inflammation. I'm just gonna say we'll have to keep our eye out on that. It's promising, but one of many different potential strategies to apply. And I was going to also maybe just answer, somebody asked a question about the monthly talk that Dr. Amjad and Dr. Serrano have created. So let me just very briefly show this slide one more time, if that's okay. There is no link for this program. So really, it's really through constant contact that information is provided about this program. But here's the information. Dr. Serrano's email is edwin.serrano@gunet.georgetown.edu, or if you're in our database, you will be getting invitations through constant contact. And again, remember, Dr. Osborne will be giving the next lecture in just a few weeks. All right, so I'll leave that up for a second. All right.
So one of the questions that I thought was very timely, I think it may have been answered already, but this might be a good one for the group. And I guess I'll direct it towards Brian because it was mostly directed toward DMTs. But in terms of the flu shot, it's that time of year. Is there timing patients need to take into consideration with their disease modifying therapies and getting their flu shot?
Yeah, so I think the big takeaway is that the flu shot is an inactivated vaccine, so it is safe in multiple sclerosis. And no matter what therapy that you are on, it is still going to increase your ability to fight off the flu. There are certain medications maybe that have theoretical risk of diminishing the efficacy of the flu vaccine. So they would recommend essentially that you would get the vaccine, Ocrevus, for example, when you're essentially about due, a couple weeks prior to when you're due for when you're going to get your next infusion. So I don't have the label in front of me, but I think it's at least 2 weeks. Someone can correct me if I'm wrong on that one, prior to your next infusion.
I do think for a lot of treatment, and this is sort of speaking generally, if it's a live vaccine or live attenuated, sometimes it's 4 weeks before treatment, and then the inactivated or non-live ones often 2 weeks. There's a general rule. Each product might be a little bit different, but I think that's a good summary. Since we have Maggie and actually Lexi on the line, I thought there were some questions that you guys answered, I guess, privately through Q&A early, but I thought maybe the group would benefit from hearing this. One of the questions was, in the study you presented, was there a control non-MS group? And then there was also a question about, was there any correlation between neuroqual scores and SES, either that was related to race? And I know you answered this for the individual people, but these might be good questions for the group.
Yeah, those were great questions. And our control group were patients who had completed the NeuroQual and PHQ-9 back in 2017. That was our control group. The variable obviously is quarantining and social isolation, and then we're comparing it to the scores now. We did not use non-MS patients as a control group. And then we haven't looked into SES yet. As I said, we're just now starting to analyze and do the stats for all the data. So that is definitely something that we could look into. Dr. Tornatore might have something to add there.
Yeah, these were great questions that came in from the audience, really sophisticated questions about control groups. And yeah, the controls were internal, so we just compared people over time. We don't have, someone asked about, well, what about non-MS patients? How does that line up? We don't have that population that we have followed to be able to compare. But we do think that the depression incidence, which is almost 50%, is much higher in our MS patients than the normal population. That's just historical. And then there was a question about, well, what about, there were variability between people who were Caucasian, African-American, and then other. And there is a difference, but we haven't really studied the difference between the two groups. But it's it gives us insight. Granted, it's a fairly modest sized study, but there are differences there. And that's what I think Maggie's cloud showed, that there are concerns that people have, and that we might even be able to tease out what some of those differences are. But it gets very, very tricky sorting all of this out. But we're learning a lot, and I think if nothing else, we've learned that we need to have more mental health counseling, and thanks to Kim Foster, who's now part of the department, we can start to offer that. But it's a very, very challenging area that we're just only starting to scratch the surface of.
Thank you. We have another question that was actually typed into the chat, and I'll let any of the panelists who want to take this can, but it was the question about, are there any new non-drug therapies that are being looked at that may help with MS, such as like food or supplements, or even just any general recommendations people have not related to disease modifying therapies?
Maybe dance would be we should add that.
I might direct that question to the National MS Society website. They have an excellent list of ongoing research for a wide range of topics in multiple sclerosis, including different diets, and different rehab regimens, kind of non-medical things. And it's very broad. They have dozens of different studies that are being funded in part by the National MS Society right now.
With the invitation to add about the dance, I'm sorry, thank you, Dr. Shan. Yes, regarding well-being, your state of mind, your emotional connection to yourself, connection to community, dance and exercise and movement has been really beneficial to the group that we meet with. So I invite you to come and try that for yourself. Thank you.
Can I make one comment? At our big MS meeting in September, I think one of the things that came out of it, addressing the non-medicinal approaches, was this idea that comorbidities, so diseases other than MS that people might have, such as hypertension, diabetes, obesity, these kinds of things, all have an impact on MS and may actually be very important modifiable risks to prevent MS disease progression or slow it down. And so it's not rocket science, but what we're learning is that if we take care, we get blood sugars under control, if cholesterol's under better control, if weight is optimal, and if exercise and activity and sleep are all adjusted, if you take all those modifiable risks, they're as important as any of the disease modifying therapies in the long term. So I know it's not sexy and it's not something that is repair related, but it is extraordinarily important that just taking good care of yourself can have an enormous impact on disability.
All right. Well, since we have Dr. Mitchell on as well, I saw a question about anticipating a COVID-19 vaccine, and you touched on this. It said one of the side effects of a certain drug is decreased efficacy of vaccines. Although actually, I'm not actually sure that's true, but theoretically, would that mean that a COVID-19 vaccine will not work as well? And they asked, should we wait to see if more than one vaccine comes out to compare efficacy rates? So do you have any thoughts on that?
I wish I had a better answer for that, but it really, it's kind of a big unknown. As you said, the research is spotty on vaccination response in MS in general, and whether or not, some therapies may preclude you from developing a robust response to a vaccination. So I would say hold out. We don't know is really quite the honest truth. We don't know. We don't know. And we don't know is a vaccination that's going to come out. I mean, we're talking about a virus here. When we think about the flu vaccination, we have, variable efficacies throughout the seasons, and you have to get routinely vaccinated throughout the year. So there are a lot of questions that are still to be answered. Is how long, if you do develop immunity, will the vaccination cover you? So unfortunately, I just have to say we don't know at this point.
There is one bright spot though, the fact that we do have an antibody for SARS-CoV-2, and so that theoretically, if somebody gets vaccinated, we will be able to see if they develop antibodies clinically. That's already commercially available. So
that's a fantastic
point. So at least we have that tool, and so we'll be able to tell if somebody does develop something.
There was another question, Erica, about the COVID-MS registry and if it had any information on how COVID-19 could affect MS symptoms.
So I did respond online. If you go through the answers, but just to kind of put it out there for everybody, is that I put the link on there to the COVID-MS registry. Everybody can access the information, and they did have a little laundry list of symptoms that people experienced with their COVID infection. But as far as how it has an effect on your MS symptoms, the website itself, the registry doesn't really address that, but you can make the conclusion that with MS, anytime you have a viral or bacterial infection, there is a risk for something we call pseudo relapse or pseudo exacerbation that Dr. Berry had discussed. So you could potentially, if you had COVID, you could have a worsening of your MS symptoms, which would improve hopefully as you are able to clear the virus.
Yeah, it has been encouraging, as you mentioned, that thus far, our patients seem to have been doing okay, even regardless of what treatment they're on. So that's great, but we'll see. So a question maybe for Dr. Berry, and actually maybe a, if you will, generic question. So people have been observing that now that there are generics available for certain products, specifically recently, I think we're at least 12, and I think we'll probably have up to 20 different generic forms of dimethyl fumarate. So the question is, are these generics different from brand, let's say Tecfidera? Is it okay if the insurance company switch, or the pharmacy really switches you from brand to generic? Do you have any comments about that?
Yeah, so I think one of the things you have to recognize is when a generic drug becomes approved, it hasn't gone through the same regulatory steps as the original drug. So what happens is the drug gets shown to be chemically equivalent in the blood, essentially. And that is what the FDA looks for to approve a generic. And so while yes, the actual chemical is the same, the rest of the packaging of the drug, other inert ingredients within the capsules themselves, the tablets themselves, can be different. I think that's really probably going to vary from generic to generic if there are several different ones on the market right now. And so, these are so new, we're still starting to get some experience with them. And, it would be a discussion that you could have with your provider about trying to, we can write certain things on the prescription to get them to dispense the brand Tecfidera. But I think maybe, as I had alluded to in my talk, there are other fumarates that are available in addition to Tecfidera, things like Vumerity, that are widely also covered. So, long way of saying it's probably a little bit adding a little bit of variability into the mix, but I don't necessarily have data that the generics are, biochemically any different or that their efficacy is any different. But I'm looking at to see like whether the tolerability might be different from generic to generic.
Just an addition to that is a lot of times with the generic, they don't offer the same support programs for patients, such as copay assistance, and that can be an issue for some patients who struggle financially.
Maybe I'll just add before Bethany jumps in, just as we all have a slightly different opinion. My feeling actually that the generics are really no different. So dimethyl fumarate is metabolized to monomethyl fumarate. Diroximel fumarate is metabolized to monomethyl fumarate. And now, as Dr. Berry mentioned, bafratem is literally monomethyl fumarate. In my opinion, these are all likely to be essentially equivalent, but everybody's different and not everybody tolerates each different product the same way. So as Dr. Berry mentioned, there are different options. You could discuss with your provider whether, we request brand medically necessary or consider one of the alternative fumarates that is, for which there's no generic alternative. So there are different strategies, but to reassure a patient, they don't check with us. So your pharmacy can switch to a generic at any time. In fact, even within a bottle, you could have multiple different generics. There's no rule about that, but I don't want to alarm, any patients who encounter that. You can just touch base with us and we can navigate that for you. So just wanted to interject.
We are getting close to the 12 o'clock hour, but Dr. Shinn, if you wouldn't mind standing in for Dr. Osborne, there is a question about should someone that has their vision affected and has been diagnosed with multiple sclerosis, should they ask to be tested for NMOSD?
That's a great question, and it really, I would say, it doesn't matter whether vision is or isn't affected in some sense, because what we've learned is that MS, NMO spectrum disorder, MOG antibody-associated disorder, they can all kind of resemble each other. So I guess my approach has been, if there's really any question about the diagnosis, it's a fairly straightforward process to get the blood tests. So these are just regular blood draws. These are not, spinal taps or exotic things. We just draw blood and we check for aquaporin 4 antibodies and we check for MOG antibodies. And it does help us to separate it out. And I think each of us probably has had the experience of patients who may have carried an MS diagnosis for a very long time. And then, later we discover, oh, it was NMO all along, or maybe it was MOG all along. So I guess I would just say if there's really any question mark, that it's certainly straightforward to have your provider go ahead and check that. These days, actually, I think many of us are more routinely checking it anyway. So it may have been checked and you wouldn't even realize it because it's sometimes part of our screening process right from the get-go. But I personally see little downside to double checking if there's any question. That kind of threw us off. We were alternating questions, but maybe I should ask the next question. We're going a little long, but there have been so many great questions. This is maybe to any of the providers. And really, I see two different questions that are sort of similar. One is asking about, well, what about for patients who are over the age of 60? We talked about discontinuation, but are there more effective treatments in that age group? And maybe kind of related would be if you're on a higher efficacy therapy, an infusion, and they use examples of things like Tysabri or Ocrevus, basically how long should you or can we continue those therapies? Somebody else asked about sort of long-term risks or side effects with really any of the MS medicines. So maybe I kind of clump them all into any kind of statement we can make about long-term use of our therapies, and again, obviously into older age groups.
I think one of the issues just that comes right to the top is that all of our clinical trials, one of the cutoff for age is 55. And so a lot of folks that are in trials, most of the trials we don't have great data on, the safety and efficacy in people who are in the 60s or 70s, with a couple of rare exceptions. So it's there's not a great roadmap for folks that are in their 7th decade or 8th decade with MS. I think, again, it's very individual. We've seen folks in their 60s and 70s with very active MS and that we have to treat aggressively. And then there are not insignificant number of folks that seem to be very stable. And then there's those that continue to progress on us. So MS, again, as I said, continues to humble us, and we just don't have really great data on people in 60s and or 70s. So it's really, at this point, clinical judgment more than anything else.
All right. Well, I'll be honest, we're right at noon, so I don't know, we may have to cut it off. I know we didn't get to every single question, but I hope that we got to most of your questions. And I think we're going to have Dr. Tornatore maybe close us out with some remarks.
Yep, let me just share the screen real quick. So just want to thank Bethany and Dr. Shin for organizing this. They start this in March, looking forward 7 months. And as you can imagine, this was being organized just in the middle of COVID, which was kind of crazy. But big thanks to the two of them for really just doing yeoman's work. And Derek, many thanks to you for all your hard work. A couple just housekeeping things here. Please fill out the evaluation form. It's going to be mailed to you within the next week or so. And again, I think the information on clinical trials, Derek has already worked through that. And then here's the link again. And again, a big thanks to our sponsors. Again, we couldn't do this without you. Really, we're very thankful. And again, the site is going to be open for the next 6 months. So you'll be able to continue to go to the virtual exhibit hall. You'll also be able to then go to the where the videos are actually kept, as Derek walked you through. So I think there's lots of content on the site in addition to the virtual exhibit hall. And so keep coming back. We'll keep adding content to it as we go along. And with that, I want to say thank you again to everyone for showing up. Clearly, this is going to be a very important part of our Patient Education Day, continuing to do the live streaming of it. Hopefully we'll be able to get to live, but then we'll be able to do both at the same time. So with that, I'm going to say thank you and have a great day.
All right. Thank you so much, Dr. Tornatore. Normally, you have a bouquet of flowers for Bethany because of all of the hard work that she does. And we just can't do that. We can't figure out how to do virtual bouquets over the computer. But this really wouldn't have been possible without a tremendous amount of work from Bethany, who I believe got up at 4 a.m. to make sure that this went smoothly. So, as always, just unbelievable how she was able to make this all work. We already talked about Derek. We already talked about Coalesce and all of our sponsors. So I'm just going to leave this slide up as we close out. As Dr. Tornatore mentioned, please fill out your evaluation form. You'll get it by email in the next week or so. Here's a website for a clinical trial. So many people asked about that. Again, thanks to all of our sponsors, and we'll see you next year.